We are about to start the session on ophthalmology, and the esteemed speaker for the session would be Dr. Manish Chhabra. But before that, let me share very important information with you. A strange phenomenon is happening. Whenever I say DVT, it echoes back to me as big, mighty, biggest. Yes, it has become the biggest medical PG prep event of the country, the DAMS DVT 2023. It's all because of you people, so eager to learn, so eager to excel in your life. But do not forget that those who laughs most learns best. So keep laughing and don't forget, apna time apun khud laega. Now next session is ophthalmology. It will be taken by Dr. Manish Chhabra, MS Ophthalmology, Fellow Glaucoma, PGI MER Chandigarh. Dr. Manish Chhabra is a qualified ophthalmologist and a trained cataract and glaucoma specialist from PGI MER Chandigarh. He is currently working as a consultant ophthalmologist at Apollo Clinics, Chandigarh and Mohali. He has been trained under world-renowned ophthalmologists in PGI MER Chandigarh and has done numerous eye surgeries, including the difficult and the complicated cases. Apart from this, he has got a keen interest in academics. He has been training undergraduates and postgraduate students from past many years, where he has been taking ophthalmology lectures and transferring the surgical skills. He has been teaching in Delhi Academy of Medical Sciences for past 6.5 years. Well, he has numerous cherished memories working with DAMC medicos, but the most funny one that he remembers, that once he was misunderstood wrongfully as a student who has come to take the class, wherein he was the one to take the lecture. That is funny indeed. So all of you, let's get ready. Let's be ready to learn as if we were to live forever. I switch on the studios now and take you to Dr. Manish Chhabra for his ophthalmology session. Over to you, sir.
All right. Am I audible and visible to all of you? Very, very good evening to all of you. This is your DAMS ophthalmology educator, Dr. Manish Chhabra. So, guys, we are going to start with our ophthalmology session. हम बस next 1 minute में 60 seconds में हम ophthalmology session start करने जा रहे हैं. And this session is going to be very crisp and very concise. And I am going to cover all the important PYTs, all the important PYQs which have been allotted to me. सारे PYTs, सारे PYQs हम cover करेंगे. I just need your presence for next 90 minutes. Right? Before I proceed forward, I want to tell you that once upon a time I was at your side. मैं आपकी side पे था. कितनी देर पहले? ज्यादा देर नहीं हुई है बॉस. It's just been 9 years. I am sharing with you the screenshot. I remember when I had appeared for All India PG entrance exam back in 2015, and I also appeared for PGI MER exam, and I was confused which subject to choose. So I messaged Sumer sir back then, and sir was humble enough to reply me at, you can check this out, it was at 12 a.m. in fact, in the night. I am confused about eye and ENT. So sir said me, Manish, go for ophthalmology, and I went on for ophthalmology, and now after 9 years I am standing in front of you as ophthalmology faculty. 9 years back I was a student just like you, and I have seen all the good times, all the bad times. I know what is the mindset of a student who is going to appear for NEET PG exam, है ना? So with same mindset today you are sitting, but who knows, after 6, 7, 8, maybe after 10 years, you are a part of ophthalmology in DAMS, or maybe any subject in DAMS. So, कुछ भी हो सकता है, right? So, without wasting any more time, let's start. जल्दी से हम start करते हैं अपनी ophthalmology. So, I am going to touch all the important points including PYTs and PYQs. Can we start? Yes, everyone. Hi, good afternoon, Praveen, Ganesh, Madhurima. It is moving, the chat box is moving at a supersonic speed. So can we start करें? Start करें, जैसे बोलते हैं ना, चलिए शुरू करते हैं, right? चलो. So yes, very warm welcome to all of you. And of course, being an ophthalmologist, how I like patients to open eyes whenever I would want to do fundus examination, but how they really open their eyes. So that is one major challenge for the patients coming to ophthalmology department for an eye checkup. है ना? ऐसी होता है ना? So that is the idea. Yes, audio video all clear. I hope it is not hanging. Audio video all clear. Please let me know, boys and girls. Audio video all clear. Yes, please, boys and girls. Okay, चलो. Let's start with the very first thing. देखिए, मैं आपको बताना चाहता हूं how my approach is going to be. I am going to give you crisp images with the clinical relevance. So you need to tell me the diagnosis, and I am going to cover all the important points with respect to that very topic. Done? Can we start? Okay, wonderful. Now coming over to the first question. Which sign do you see? This is your NEET PG 2018 question. जल्दी बताइए, समय नहीं है हमारे पास. So which sign do you see? Which sign do you see? What is this sign? Yes, boys and girls. And what is this condition? This sign, what you can see here is, this is, boys and girls, teardrop sign. आपको पता है बच्चों, you already know it. This is your teardrop sign. And you see this sign in blunt trauma of the orbit condition. Your PYQ, blunt trauma of the orbit. Blunt trauma of the orbit. This is your teardrop sign. And what is this white thing hanging? What is this white thing? This is intraorbital fat, and it is seen when there is inferior fracture of the orbit. जब orbit का inferior wall fracture होगा, तो then there will be herniation of the intraorbital contents in the maxillary sinus. जिसको हम बोलेंगे, क्या बोलेंगे? You already know it. It is your teardrop sign. Very good. But ये भी एक sign होता है. इससे एक गाना मेरे माइंड में आ रहा है. कौन सा गाना? घुंघरू टूट गए, है ना? बट लेट्स जस्ट नॉट गेट इनटू दिस. चलो अब आगे चलते हैं. कमिंग ओवर टू अवर नेक्स्ट क्वेश्चन. चले आगे चलें. यस, अवर नेक्स्ट पेशेंट की अगर हम बात करें, अ 65-year-old डायबिटिक फीमेल विद इथमॉइड साइन्यूसाइटिस प्रेजेंट्स विद दिस. तो ये कंडीशन है, राइट? मोस्ट डेडली कॉम्प्लिकेशन. उसके बाद अर्लीस्ट क्लिनिकल साइन ऑफ इन्वॉल्वमेंट ऑफ. पहली बात, टेल मी द डायग्नोसिस. जल्दी बताइए क्या डायग्नोसिस होगा. क्विकली, क्या क्या फीचर्स आपको दिख रहे हैं? आंखें बाज की तरह होनी चाहिए. आई हैव टू हैव योर आईज लाइक आईज ऑफ एन ईगल. जल्दी बताओ क्या दिख रहा है यहाँ पे? पेरी ऑर्बिटल इडीमा. से यस और नो बताइए. पेरी ऑर्बिटल इडीमा इस सीन दिख रहा है कि नहीं? यस और नो जल्दी बोलो. बोलना है. अपने रूम में, लाइब्रेरी में, वेयर एवर यू आर अटेंडिंग द सेशन, यू हैव टू स्पीक. पता लगना चाहिए पड़ोसियों को, घर वालों को कि आप डैम्स की डीवीटी ऑनलाइन रिकॉर्ड कर रहे हो, अटेंड कर रहे हो, राइट? ओके, चलो. व्हाट इज दिस? द प्यूपिल इज डायलेटेड. दिस इज कंजंक्टिवल. मेरे साथ लेबलिंग करेंगे. कंजंक्टिवल कीमोसिस, पेरीऑर्बिटल इडीमा, डायलेटेड प्यूपिल, कंजंक्टिवल कीमोसिस. किसकी तरह? व्हाट इज योर डायग्नोसिस? डायग्नोसिस है ऑर्बिटल सेलुलाइटिस. गॉट इट? नाउ विच इज द मोस्ट डेडली कॉम्प्लिकेशन? डेडली कॉम्प्लिकेशन की बात कर रहा हूं. डेडली कॉम्प्लिकेशन, पेशेंट कैन इवन डाई. सो मोस्ट डेडली कॉम्प्लिकेशन, योर प्रीवियस ईयर क्वेश्चन ऑफ ऑर्बिटल सेलुलाइटिस, माय डियर बॉयज एंड गर्ल्स, इज व्हाट इज दिस? इट इज CST. क्या? छत्रपति शिवाजी टर्मिनल ऑफ बॉम्बे? नो, इट इज कैवर्नस साइनस थ्रोम्बोसिस. इट इज, लिखेंगे मेरे साथ, कैवर्नस साइनस थ्रोम्बोसिस. यस, दैट इज द मोस्ट डेडली कॉम्प्लिकेशन. चलो एक और इंटरेस्टिंग चीज आपको बता देते हैं. Now, if the patient has come to you with orbital cellulitis, with the complication of cavernous sinus thrombosis, मान लीजिए right eye में it has to be cavernous sinus thrombosis. Now, clinically, you are a गरीब doctor. You are sitting at the peripheral center. एक होता है अमीर डॉक्टर who sits in an air conditioned room, पूरा centrally air conditioned, but unfortunately you are posted in a primary health center. अब आपको पोस्ट कर दिया गया एक विलेज के अंदर, right? Now you have to diagnose the further complication of orbital cellulitis, which is cavernous sinus thrombosis. Now the patient has got cavernous sinus thrombosis on the right side. Now you are suspicious that the same problem can happen to the left side as well. Ab, you are sitting in a peripheral OPD, so you don't have an access to what? You don't have an access to MRI. So how do you know whether the left part of the cavernous sinus is also involved or not? बताइए कैसे पता लगेगा? For that I need to show you one image. What is that one image? I need to show you this image. देख पा रहे हैं? ध्यान से देखो, गौर से देखो इस बहरूपिये को. क्या है ये बहुत बहरूपिया वाली इमेज है. क्या इमेज है? देखो, if the other side of the cavernous sinus is involved, so clinically you can actually tell whether this side is involved or not. How? So by seeing one important sign. What is that one important sign? देख पा रहे हो? Which are the nerves which are passing through the cavernous sinus? Okay, this is oculomotor, this is trochlear, ophthalmic, maxillary, part 2 again, the branch of trigeminal nerve. But what about this nerve? This nerve is your abducent nerve. This is your abducent nerve. If there is involvement of the other part of cavernous sinus in cavernous sinus thrombosis, so the nerve which is passing through the center of cavernous sinus will be involved first. समझे? Now the nerve which is passing through the center of cavernous sinus, which is involved first, which is abducent nerve, and you know abducent nerve supplies which muscle? Lateral rectus muscle. So the earliest clinical feature or the earliest sign that you will see in the involvement of the other side of cavernous sinus is abduction defect. Abduction defect. So the left eye will not be able to abduct because it is done by lateral rectus, and lateral rectus is supplied by abducent nerve, which is suffering from the complication of cavernous sinus thrombosis. Got it? Yes or no? Yes. समझ गए? Very good Ruchira. Very good Shubham. Yes, yes. Very good Minakshi. You all are doing wonderful. Wonderfully. Wonderful. Wonderful. I'm so proud of you. So, I have given you the answer. Earliest clinical sign is abduction defect. Abduction defect. Why? Due to involvement of 6th cranial nerve. लिखेंगे मेरे साथ 6th cranial nerve, and there will be LR palsy. Your previous year question, I told you, whatever topics that I am going to teach you, I am going to cover all the PYTs, all the PYQs, and the potential questions as well. Mind you, yes. So, bilkul, I want you to open your eyes like eyes of an owl. I want you to be wide awake, right? Okay. And important point I want to tell you here is that if I am talking of orbital cellulitis, which is the most common sinus involved in orbital cellulitis, maxillary sinus? No. Sphenoid sinus? Nah. Ethmoid sinus is the answer. So, please write, already it is written, but your previous year question, I want to cover it. Ethmoid sinus is most common sinus. Boys and girls, it is involved in orbital cellulitis. Your again previous year question. Done? Chalo, and I hope that you are wide awake. I have got my eyes on you. Mind you, I have got my eyes on you, right? चलो, जल्दी चलते हैं आगे. ये मैं आपको already, I have already explained to you. This is the image of your cavernous sinus. You must have gone through this image 100,000 number of times in your BDC की book. Got it? Okay. Now, important question is, what are the clinical features of cavernous sinus thrombosis? Now, earlier, the disease was confined only to the orbit. Disease was confined only to the orbit. Now, when the cavernous sinus thrombosis has happened, so now the disease has traveled to the cavernous sinus. Got it? Now, if the central nervous system is involved, there will be central nervous system features. What will be those features? What will be those features? Ataxia and disorientation, drowsiness, and patient may even land up in coma, and this is a life-threatening condition. Don't have to write, just need to understand and conceptualize it. Earliest sign, I have already told you. What will be the treatment? I always say in my class, if you know the etiology, boys and girls, you know the treatment. If you know the pathogenesis, you already know signs and symptoms. This is the right thumb rule of your medicine. Got it? Okay. Now, treatment. Because orbital cellulitis, which is the most common organism causing orbital cellulitis, your PYQ, another PYQ, most common etiological agent. बताइए जल्दी, बताइए भाई, 3 महीने बाद एग्जाम है बच्चों. After 3 months you are going to have exam. It is Staph aureus. Staph aureus is the most common etiological agent. Now, if you know the etiology, you know the treatment. Which antibiotic is effective against Staph aureus? Jaldi bataiye. Sir, penicillin. No, bachcho, it is not penicillin because penicillinase resistant Staph aureus is present. So, what will be your drug of choice? Single drug of choice, boys and girls. Yes, yes, drug of choice kaun si hogi? Drug of choice will be, yes, waiting for your answers. It is IV vancomycin. Vancomycin plus you will also give third generation cephalosporin. You can top it up with third generation. Very good, all of you. Harshit, Shabina, Sheen, Aparna, very good. Cephalosporin. Cephalosporin. If asked single drug of choice, go for intravenous vancomycin. Got it? Okay. And of course, we are talking of thrombosis. So you will give thrombolytics, heparin, tissue plasminogen activator. And of course, you would want to decrease the meningeal inflammation as well by giving steroids. So you can top it up with steroid. But please don't give only steroids. It will flare up the infection. So you have to give steroids under very beautiful antibiotic cover. Got it? Yes, got it. Chalo. Now going over to our next condition. So next is, so this is your case of thyroid eye disease, right? Now I want to go towards your previous year question and previous year topic. So what is your earliest, bataiye, what is your earliest feature or sign of thyroid eye disease? Yes. Now you will say, sir, we know. What is this? This is proptosis. No, boys and girls, this is not proptosis. The earliest feature or earliest sign of thyroid eye disease is not proptosis. It is your Dalrymple sign. Now you say, sir, Dalrymple sign, ये तो हमने अभी तक पढ़ा ही नहीं है. क्यों नहीं पढ़ा भाई? डैम्स अटेंड किया है ना? डैम्स अटेंड किया तो पक्का पढ़ा होगा. Dalrymple sign is upper eyelid retraction. Upper eyelid retraction. Upper eyelid retraction. This is your earliest sign of thyroid eye disease. But there are other signs as well. Quickly just write other signs so that if the question comes, you should be able to mark it correctly. Right? Now there is Von Graffe sign. Von Graffe sign. Von Graffe sign is lid lag in down gaze. Lid lag in down gaze. Third is Mobius sign. Mobius sign is convergence insufficiency. Convergence insufficiency. समझे? Convergence insufficiency. एक और साइन कर लेते हैं. Stelvaux sign. Stelvaux sign. Stelvaux sign is infrequent blinking. So these are all important signs. Infrequent blinking. Now you need to understand what happens in thyroid eye disease is there is fibrosis of extraocular muscles, right? Or how many extraocular muscles are there? Guys, extraocular muscles are 6 in number, out of which 4 are recti, 2 are obliques. You already know it. What are 4 recti muscles? Sir, inferior rectus, medial rectus, superior rectus and lateral rectus. Done? Done? And next is there are 2 obliques. What are those 2 obliques? Sir, superior oblique and inferior oblique. Now, if I talk about the involvement of extraocular muscles in thyroid eye disease, so there is inferior rectus, there is medial rectus, there is superior rectus and there is lateral rectus. So this is the sequence of recti because recti are involved first. Now, how will you remember? There is a mnemonic. I am so lucky. So how will you remember? So I am so lucky. And later obliques are involved. So if I may ask you your previous year question, NEET PG 2017, 2017 mein, this question was asked, which is the earliest extraocular muscle involved in thyroid eye disease. What is the answer? Sir, inferior rectus. Very good. Which is the earliest recti muscle which is involved? Sir, inferior rectus. Of course, yes. So these are the questions. Done? Done? Got it? So this is the sequence of involvement of extraocular muscles in thyroid eye disease. Okay, wonderful. Now I want to show you what is this test. Can you tell me? What is this test? Can you tell me? Yes. What is this? What is being done? So this is your test, which is your forced duction test. Forced duction test. Now, forced duction test is a test which is used to differentiate between paralytic squint and restrictive squint. So, it is used to differentiate between paralytic squint and restrictive squint. Now, you know that in thyroid eye disease, there will be which sort of squint? There will be restrictive squint, which will be in thyroid eye disease, while paralytic squint is the form of a squint in which there is paralysis of the muscle, while in restrictive squint, it is due to fibrosis of extraocular muscle. Fibrosis of extraocular muscle. Fibrosis. Now, I am quickly going to tell you what happens. So, in thyroid eye disease, there is deposition of glycosaminoglycans. You call it as GAGs. When there is deposition of glycosaminoglycans, first it is always deposited in the inferior rectus. Then it is deposited in the medial rectus. Then it is deposited in the superior rectus. This is the sequence of deposition of glycosaminoglycans in the extraocular muscles. Done. Now, post this inflammatory response, post this deposition of glycosaminoglycans, there is fibrosis, and when there is fibrosis, so the muscle will get short. So once the patient comes to you, let's say with right hypotropia, hypotropia means right eye is pulled downwards. Now you are confused whether this right hypotropia is due to fibrosis, pulling of the right inferior rectus, or the paralysis of right superior rectus, right? For this, you will perform this test, which is forced duction test. What you are going to do? You are going to take the forceps, put it on the superior limbus. What is limbus? Limbus is sclerocorneal junction. Try to pull the eyeball upwards. So, whenever the patient comes to you, you need to move the eye in opposite direction. Right here, the patient's eye is outside. So, you will try to move the patient's eye inside. If on pulling the eyeball upside, in the case of right hypotropia, if the eye moves upside, 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 that means the patient is having paralytic squint. If the right eye is not able to move upside by your forcefully pulling it up, that means something is holding the eye from below, right? So in that case, you will call it as restrictive squint. So in this very case, if I move the eyeball on this side, if I try to move the eyeball on inner side, if it moves, that means the patient is having right medial rectus palsy. If the eye does not move on the medial side, so that means the patient is having right lateral, or in this case, this is the left eye, so left lateral rectus fibrosis. Have you understood? Yes, समझे? जल्दी बताओ, जल्दी जल्दी जल्दी. Yes, quick quick quick. I need your answers. I don't want you to be sitting idle like ऐसे, जैसे बीच पे बैठे हो और आराम से सामने चल रहा है. No, it should not be like this. I want your active participation. भाई वॉल्यूम नहीं रिड्यूस होएगी, वॉल्यूम नहीं रिड्यूस होएगी. अब मैं चंडीगढ़ से ही बोलूंगा तब भी आपके घर में सुनेगा ये, है ना? चलो, जोक्स राइट. चलो, यस यस यस. चलो, कमिंग ओवर टू आवर नेक्स्ट इंपॉर्टेंट फीचर. व्हाट इज दिस? क्या है ये? क्या है ये? व्हाट इज दिस? सो दिस इज योर वन इंपॉर्टेंट साइन दैट यू डू इन थायराइड आई डिजीज. थायराइड आई डिजीज का वन इंपॉर्टेंट साइन है. व्हाट इज दिस टेस्ट? इस टेस्ट का नाम है बच्चों नैफ-जिगर टेस्ट. Nabziger test bolo, Nabziger sign. What do you do in Nabziger test? So you are sitting in a peripheral center. You don't have an access for quantitative measurement of your proptosis, right? So what you do, you stand at the back of the patient, ask the patient to look upwards. When the patient is looking upwards, you stand at the back of the patient, look out for the relative position of the eyeball. In this very case, can you see something? Can you see something that this eye, which is right eye, slightly protruded upwards? So that is going to tell you qualitatively, it is going to tell you qualitatively about proptosis. But important thing to remember. So one word is proptosis. Another word is exophthalmos. Can you tell me what is the difference between proptosis and exophthalmos, boys and girls? Yes. Yes, yes, yes. What is the difference between proptosis and exophthalmos? Let me tell you, exophthalmos is nothing but proptosis which is seen in thyroid eye disease. It is something like Ram, when he was in India, he was Ram. When he went to Canada, he changed his name to Rambo. But the person is same, na? So similarly, proptosis in thyroid eye disease is exophthalmos. Don't get confused. Sir, at some places I am reading exophthalmos, while in some cases I am reading proptosis. What is the difference? Are they both different? No, my dear boys and girls, both are same. It is just the thyroid eye disease, proptosis. Got it? Very good. Very good, very good. चलो, अब what is this? ये बताइए, what is this? क्या है ये? This is your recent exam question, भाइयों और बहनों. Recent exam question. So this recent exam question, what is this? This is your exophthalmometer. Exophthalmometer. But this exophthalmometer measures the extent of proptosis. So Nabziger test is used for qualitative proptosis, while exophthalmometer is used for quantitative proptosis. Quantitative. Now you will say, okay sir, quantitative, but when we will say that the patient is having proptosis? We will say when the patient is having proptosis, when the distance of center of the cornea from the lateral orbital rim is more than or equal to at least 21 millimeter. Some books mention 20 millimeter. So 20 to 21, based on the options you can mark one. है ना? More than equal to 21 millimeter. So what is this? This is the distance of lateral orbital rim and center of cornea. समझ पा रहे हैं? Center of cornea. So this is but important point, another important point, your 2 PYQs. If you are measuring the exophthalmos in child, what is the name of that exophthalmometer? जल्दी बताइए. What is the name of that exophthalmometer? So name of that exophthalmometer is Ludy's exophthalmometer. If I am doing this in child, but if I am doing the same measurement of proptosis in adults, you call it as Hurtles. Very good. अरे यार आप तो बहुत इंटेलिजेंट हो, सब कुछ ही आता है आपको, है ना? यही बात है डैमसोनियंस की, राइट? ओके, सो Hurtles is used in adults. Hurtles in adults, Ludy's in child. Done? Yes, good to go. जल्दी बताइए, good to go. Okay. Dear Neeraj, Nabziger is qualitative assessment. You don't measure anything. You just look out for relative position of the eyeball. Qualitative. Quantitative is you actually measure how much is the proptosis. 21 mm, 21.1, 2, 3, 4, 21.5, 22, 22.5, so on. Got it? चलो आगे चलते हैं. Now tumors of the orbit. I am giving you 4 direct MCQs. 4 direct MCQs. Brownie points. Rhabdomyosarcoma. It is most common intraorbital malignant tumor of orbit. Most common intraorbital malignant tumor of orbit. Rim के बाद and लिखा है. Rim and center of cornea. Okay. Most common intraorbital malignant tumor of orbit. But मुझे पता है where you commit one mistake. I am talking of intraorbital. अरे मैं इतनी पास आ रहा हूं, ऐसे लग रहा है कैमरा में घुस जाऊंगा. I should go back, है ना? चलो. So intraorbital की बात करें. If I am talking of intraorbital tumor, it has to be which? It has to be your rhabdomyosarcoma. But most common intraocular malignant tumor. Intraocular malignant tumor. देखो, there's a difference between intraorbital and intraocular. So in children it has to be retinoblastoma. Don't get confused. I receive many messages, sir, you have taught rhabdomyosarcoma, but the answer says retinoblastoma. Sir, what should we do? Bhai, intraorbital and intraocular are two different things. Intraorbital means inside the orbit. Intraocular means inside the eyeball. Got it? Okay, wonderful. आगे चलते हैं. Now dermoid cyst is most common intraorbital tumor in children which is benign. So that is your dermoid cyst. Got it? Your second MCQ down. In fact, third. I gave you one brownie na, retinoblastoma wala. Orbital lymphoma is most common intra-orbital, all are intra-orbital tumors. Tumor malignant in adult, it is orbital lymphoma. So it can be non-Hodgkin's lymphoma. If that is not in the option, you can go out for orbital metastasis. Metastasis means metastasis from some distant site or metastasis. Got it? Chalo. Got it? Yes, 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 yes. Okay, okay. You can write it down, Vivek. Yes, I hope it is clear now. Good, good to go. Yes, 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 good to go. Okay, okay. So cavernous hemangioma is again intraorbital tumor, but it is benign intraorbital tumor in adults. Benign intraorbital tumor in, benign, yes, yes, yes. Zoom, you want to zoom in or zoom out? Benign intraorbital tumor in adults. Yes, yes, yes. Benign in adults. Got it? Cavernous hemangioma. Okay, Krutarth, got it. Benign in adults. Benign in adults. But I am giving you one brownie MCQ. Most common intraocular. भाई अगर आप धीरे बोलोगे तो मैं पता है कैसे पढ़ाऊंगा. Most common intraocular tumor which is malignant in adults. So it will be malignant melanoma. नहीं आया ना मजा? नहीं आया ना? तो इसलिए जो स्पीड चल रही है बल्ले बल्ले करो उस पे. Malignant melanoma. Malignant melanoma or choroidal melanoma. Very good. Yes, Sayan. Yes, Akshay. Arey, wonderful. Choroidal melanoma. So both are one and the same thing. You can mark. दोनों का भी ऑप्शन में नहीं होंगे. All right. Got it? Yes. Should I move ahead? Yes, boys and girls. चलें आगे. All right. Okay. Now moving ahead, coming over to our next question. Yes, coming over to our next question. So yes, 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 yes. All right. All right. All right. All right. Yes, yes, yes. Got it? So I am quickly repeating. Most common benign intraorbital tumor in children is dermoid cyst. In adults is cavernous or capillary hemangioma. Most common malignant intraorbital tumor in children is rhabdomyosarcoma. In adults is non-Hodgkin's lymphoma or metastasis. 4 MCQs down plus 2 brownie MCQs. 2 brownie MCQs सब्जी के साथ कड़ी पत्ता हरा धनिया फ्री. हमारे यहाँ तो भाई ऐसा ही चलता है. 2 more MCQs. One is most common malignant intraocular tumor in children, retinoblastoma. Most common malignant intraocular tumor in adults is choroidal melanoma. Got it? Chalo. Done? Okay. Now next is uveitis. A 25-year-old male comes with these diagnosis. Please. Oh wow. A 25-year-old comes with these diagnosis. Please. Bataiye. Yes, quickly. Yes, yes, yes. Okay. Now what is this? This is your circumcorneal congestion. Circumcorneal congestion. Circumcorneal congestion. What is this? ये क्या है? This is your hypopyon. Hypopyon. What is this? This is your, what is this? This is your Arl's triangle. Arl's triangle. And these are your keratic precipitates. Very good. Keratic precipitates. All of you are answering beautifully. Yaar, I am so proud of you. Keratic precipitates. And these keratic precipitates are kind of thick in color. So these are granulomatous capes. Or you can say mutton fat capes, है ना? So mutton fat capes. So this is a condition of uveitis. So now I am going to tell you what is the earliest feature of uveitis. Jaldi batao, because I know you are getting confused. Whenever I ask or the examiner asks which is the earliest feature of uveitis, you will say, sir, proteins in the anterior chamber. Bhai, haath jodwa lo. It is not proteins in the anterior chamber. It is actually cells in the anterior chamber. That is the option to be picked. Galti nahi karni hai. This galti can lead to great, bad. You already know it, है ना? Okay. So earliest feature, you don't want to have that bad consequence, है ना? Earliest sign earlier. No, it is not aqueous flare, boys and girls. It is not aqueous flare. Flare is due to proteins in the anterior chamber. Bhai, I am not talking of proteins in the anterior chamber. I am talking of cells in the anterior chamber. So earliest signs will be cells. Dear Muthu Ganesh, I am speaking everything in English. Just that some few gimmicks or few just jokes I am talking in Hindi, right? So don't mind, है ना? So earliest sign is cells in the anterior chamber. KPs. So earliest sign is cells in the anterior chamber. If cells is not in the option, then you will go on for proteins in the anterior chamber. Samjhe? And flare is not due to cells. Flare is actually due to proteins in the anterior chamber. So if the cells is not given in the options, then you will mark proteins. If proteins is not, then you can mark aqueous flare. Got it? Samajh pa rahe ho? Got it? Okay. And what will be the treatment? If you know the etiology, you know the treatment. If you know the etiology, you know the treatment. Etiology of anterior uveitis most commonly is idiopathic. So यहाँ पे लिखूंगा मैं. So most common etiology of anterior uveitis is idiopathic. समझ में आया ना? Idiopathic. But there is granulomatous anterior uveitis as well. Granulomatous, I told you na, mutton fat KPs are seen in granulomatous. If I talk about granulomatous anterior uveitis, so we have tuberculosis, your previous year question, syphilis and leprosy. Very, very important. Tuberculosis, syphilis and leprosy. So if I talk about granulomatous anterior uveitis, if I talk about usual anterior uveitis, done. So it will be idiopathic. So what will be the treatment of general treatment of anterior uveitis? So it will be steroids. कौन से steroids देंगे? You will give topical steroids. Done. And you are also previous year question. If I talk about the complications of anterior uveitis, if I talk about, so drug of choice will be topical steroids. Of course, you will also give mydriatic agent or you will say cycloplegics. If I talk about cycloplegic, so cycloplegic mein what will you give? Steroids plus cycloplegic. Cycloplegic you can give homatropine. Got it? Okay. Now what will be the complication of anterior uveitis, on which there are two questions. One is most common complication. Second is second most common complication. So most common complication of anterior uveitis is, yes, it is cataract. And cataract is due to posterior synecdoche. Cataract is due to posterior synecdoche, number one. Second, if the cataract is not given in the option, then second most common complication is glaucoma. And glaucoma is due to anterior synecdoche. Now, if I may ask you, which synecdoche is more common in uveitis? Of course, it will be posterior synecdoche, and posterior synecdoche leads to cataract. That is why cataract is more common than glaucoma. Got it? Yes, please. Yes, please. Yes, Sahil, you are good. Very good. Angle closure, yes, it can lead to angle closure glaucoma. Got it? Okay, so these are two important things because these both are your PYQs. Now, what is this diagnosis? What is this? Yes, boys and girls. What is this diagnosis? So I am writing it here. This diagnosis is, what is this diagnosis? This is your band-shaped keratopathy. This is also one of the complications of anterior uveitis. It is band-shaped keratopathy. Band-shaped keratopathy. Band-shaped keratopathy. What happens in band-shaped keratopathy? What happens in band-shaped keratopathy? There is deposition of calcium and phosphorus. So there is deposition of calcium and phosphorus in which layer of cornea? Your previous year question. In Bowman's layer of cornea. Bowman's layer of cornea. Now you need to tell me what will be the treatment of band-shaped keratopathy. Now you will say, sir, calcium and phosphorus. So in calcium and phosphorus, we can give chelating agents, or some students may call it as chelating agents. I still remember when I was preparing for my pre-medical entrance exam. So a faculty came and he started to teach something very unusual. So for good half an hour, he kept on saying, so this is this pungi, this is this pungi, this is this pungi, and we could not get anything. But after 30 minutes, so we thought, is he actually talking of pungi, some new organism, or fungus or fungi? So he was calling it fungi. So that is why I am telling you, you can call it as chelating agent or chelating agent. Now in calcium and phosphorus excess condition in the body, you can go on for chelating agent. What is that chelating agent? So you can go on for, yes, very good Sonam, you can go on for EDTA. But cornea is vascular or avascular? Sir, cornea is avascular. So when you will give intravenous EDTA, will it reach cornea? No sir, सवाल ही नहीं पैदा होता. Of course you are correct. Very good. So you will give which form? You will give topical EDTA. Your again previous year question. One more question down. So we are downing each and every question after passing 1 or 2 minutes. Done? Okay. Done. Yes. Got it? Yes. Wonderful. So now, after having done this, so I hope it is very clear. So band-shaped keratopathy. Okay. Now 3 simple spot diagnosis. Of course, I know you are feeling a little hungry, but that's okay. After DVT, you will have ample time to order Domino's. रात को 11 बजे तक खुला होता है. In some metro city, it is even open till 1 a.m. So that's absolutely okay. So a patient is having a history of HIV, your previous year question. So this is your CMV. Yes, very good. Retinopathy. CMV, retinopathy. And of course, I don't have any financial interest in this. Domino's वालों ने मुझे पैसे नहीं दिए, but हाँ, it is open. अगर वो अगली बार से मुझे पैसा देना चाहेंगे तो मैं एक की बजाय 2 Domino's के स्टिकर लगा दूंगा. I don't have any problem with that, है ना? Yes, influencers का जमाना है ना? चलो, okay. So CMV retinopathy, and which is this fundus? So you call it as pizza pie appearance. Pizza pie appearance. Done. My dear Aishwarya, it is not splash tomato appearance. Splash tomato appearance is seen in central retinal vein occlusion. Got it? I hope it is clear you. है ना? Okay. Alright. So this is your pizza pie appearance. Another important question which was asked just 4 months back. What is the treatment of CMV retinopathy? Just single line. Ganciclovir. Ganciclovir. Ganciclovir is drug of choice. Ganciclovir is drug of choice in CMV retinopathy. Done. चलो. Now patient with granulomatous uveitis. जल्दी बताओ what is this? क्या है ये? सर ये तो मोमबत्ती है. हाँ भाई मोमबत्ती है. देखिए what is this? So this is your, yes. This is your candle wax dripping appearance. It is seen in which condition? It is seen in which condition? It is sarco. अरे wonderful यार, कमाल के बच्चे हो यार, आप तो कमाल ही कर दिया. So it is sarcoidosis. It is sarcoidosis. Very good, candle. So a question can be asked, can you see the small dots? So it is looking like these are dripping candle wax, right? Done. Okay. Sarcoidosis. Next is, बताइए, patient with toxoplasma infection. What is this? This is, chalo, I am going to give you hint. What is this? What is this? Fast and Furious 9. Dom Tornado. Jaldi batao, what is this? This is your headlight in fog appearance. Very good, yeah. Too good. Headlight in fog appearance. Typically seen in your toxoplasma uveitis. Toxoplasma uveitis. Got it? चले आगे. चलो. Identify this condition. Yes, boys and girls. What is this? What is this? क्या है ये? ये पता है मैं कब यूज करता हूं? जब पूरी सब कुछ पढ़ाओ और उसके बाद भी अगर ऑप्थेल्मोलॉजी में कोई गलती करके आते हैं ना स्टूडेंट, तो उसको मैं इनवाइट करता हूं कि मैं आपकी काउंसलिंग करूंगा, आ जाओ. फिर जब वो आते तो मैं एक हाथ में चाइजल पकड़ता हूं, दूसरे हाथ में हैमर पकड़ता हूं, ठक ठक ठक. And if you don't want this to happen to you, so you need to be very well aware that you have to read ophthalmology, right? Or ophthalmology is the most scoring subject, right? So this is your chisel and hammer, number 1. This is your, of course, the sutures. You can see the sutures. अच्छा मुझे बताओ which sutures are applied in the cornea. So boys and girls, these are 10-0 nylon sutures, your previous year question. and of course it is depicting that there is some penetrating injury or perforating injury. That is why you applied suture now. What is this? These are KPs. Now these KPs are big, so these are granulomatous KPs. Granulomatous KPs, right? And what is these? क्या है ये? These are your Dehlen Fook nodules. Dehlen Fook nodules. So if you connect the dots, chisel and hammer, corneal injury, granulomatous KPs, Dehlen Fook nodules. So boys and girls, this is your sympathetic ophthalmitis. Ophthalmitis. So someone is writing FUCH Fook. जल्दी जल्दी में मैंने FUCH को कुछ और पढ़ लिया. Oh, I'm so sorry. Just that Fuchs है ना, Fuchs. But this is not a case of Fuchs. This is sympathetic ophthalmitis. Got it? Okay. Now, what is the earliest sign of sympathetic ophthalmitis? Earliest sign is what doctor sees. Earliest symptom is what patients comes to you with. So earliest sign is retrolental flare. Retrolental flare. So it is your retrolental flare. Earliest symptom, these are two important PYQs. So earliest symptom is loss of accommodation. Loss of accommodation. So someone is asking me, sir, what is Dehlen Fook nodules? So guys, what happens is, this is a condition of granulomatous uveitis, right? Dehlen Fook nodules are the pigment, because in sympathetic ophthalmitis, the antibodies are formed against the uveal pigment. You already know now, whenever there will be injury, there will be pigment dispersion in the bloodstream. But the uveal pigment is a sequestered antigen. That means this pigment has never been exposed to the bloodstream of the patient. So as a result, the patient's body will take this uveal pigment as a foreign antigen. So the patient's body will start producing antibodies against this uveal pigment. So one eye is already damaged due to injury, but the other eye, the same uveal pigment is there now. So the antibodies which are formed in the body against this uveal pigment, it will enter through the blood uveal barrier in the other eye and will destroy the other eye's uvea, right? So now the antibodies engulfing the uveal pigment, that is known as Dehlen Fook nodules. अब ये ज़्यादा मैं डिटेल में नहीं लिखवा रहा हूँ, because it is the pathogenesis and this is very crisp and concise class, but I have already spoken it. You can rewatch the video, or you can go back and see my back to basics where I have very nicely explained everything. Done? Okay. So that is Dehlen Fook nodules. That is seen in sympathetic ophthalmitis. What is the most dangerous period? Most dangerous period is the period in which the antibodies are formed. So antibodies are formed in 2 weeks to 2 months. So most dangerous period, your previous year question. Yes, dear Samia, SO occurs in other eye. The same eye, the one eye is already damaged now due to primary trauma. So sympathetic ophthalmitis, so it looks like in sympathy to the damaged eye, the other eye self-damages itself. It is not actually the self-damaging component. It is actually the antibodies which are formed and entering the blood uveal barrier of the other eye. So that is the name, sympathetic ophthalmitis. So 2 weeks to 2 months. Got it? Yes, Fatima, very good, very good. Of course, yes, Dr. SF, yes, very good, Madhurima, yes, very good, very good. What will be the treatment? Now, treatment, there can be 3 conditions. One is the normal eye. The normal eye has vision 6/6. The traumatic eye has vision of PL negative, means the eye which had injury cannot see anything. So what you will do, you will simply go for enucleating or enucleation of traumatic eye, because if you will leave it there, so one eye is already lost now. If you leave it there, there will be formation of antibodies and it will damage the other eye as well, and as a result the patient will go blind. So you don't want that to happen. This is your first condition. Done. Now coming on to second condition. Second condition is normal eye is 6/6, but abnormal eye is 6/36. That means the abnormal eye has good amount of vision. PL negative to completely gone na. So in this case, what you are going to do? You are going to give high dose steroids. You will not enucleate the abnormal eye because 6/36 is a good vision, and there are just 1 to 2% of chances of sympathetic ophthalmitis in all the injuries. Only 1 to 2% of the patients will land in sympathetic ophthalmitis. Now, अगर जरा भी trauma होता है, सबकी आंखें थोड़ी ना निकालते फिरोगे आप, right? So you will just give high dose steroids. Third, if the normal eye, so the patient has come to you late, the normal eye which did not have any trauma, this eye has got SS, means signs and symptoms of sympathetic ophthalmitis. I am talking of normal eye. But the abnormal eye which had trauma, the abnormal eye which had trauma is PL negative. Now what will you do? Are you going to remove the normal eye? अरे भाई normal eye को तो बचाना है. Patient की 3 आंखें थोड़ी ना है. The patient is not having 3 eyes. The patient is having only 2 eyes. So of course one eye is already PL negative, but the patient arrived to you after 2 weeks or maybe after 3 weeks, so that the other eye has developed signs and symptoms of sympathetic ophthalmitis. So what you will do? You will again give high dose steroids. Why? Because the exposure has already happened, है ना? So even if you remove the abnormal eye or traumatic eye, IgGs will still be present, na? Understand? Can you recall the concept of RH isoimmunization, है ना? So once the antibodies are formed, they are going to remain in the body for the rest of the life. So enucleation in the first case, first scenario, was only to prevent the antigen exposure to the bloodstream, but here the antigen exposure has already happened. PL means perception of light. PL means the patient is not able to perceive the light at all. So that is PL, perception of light. Okay, so here you will again give high dose steroid, and in second case you will also repair the eye, na? So you will also go for repairing the eye. Primary repair, that is very important. So second condition, of course you will repair the eye and you will give steroids, right? Lekin if both are given in the option, so first you will mark primary repair 1, second you will mark high dose steroids in second case, but in third case you will give high dose steroids. Done? Understood? Yes, jaldi batao. Ayan, I am saying there can be 3 conditions. One is the traumatic eye has PL negative, the other eye has good vision. Very good. 6/6. Nothing has happened. So you will remove the traumatic eye because the patient has come to you early. One eye is already PL negative, although the chances of developing sympathetic ophthalmitis is just 1 to 2%. But still you will not want to take risk. Number 1. Second is the patient has abnormal eye, traumatic eye, good vision, 636, 624, 618, 660, whatever. But the other eye is normal. So you will do primary repair. You will not remove the eye with good vision. 6/36 is, come on yaar, very good vision. नहीं, अगर मैं specs उतार दूंगा, my vision is 6/36, right? Have you understood? So in that case, first you will go for primary repair. Second, you will give high dose steroids, option wise. Otherwise, primary repair plus high dose steroids. Got it? Second. Third, the traumatic eye has developed the signs and symptoms of sympathetic ophthalmitis in the other eye. So in that case, the exposure has already happened, na? So there will be no point of removing the traumatic eye, है ना? क्योंकि PL negative है. So you will not remove. Why to give another trauma to the patient? So what you are going to do? You are just going to give high dose steroids, nothing else, है ना? और साथ में मंदिर में दिया जला के आओगे कि sympathetic ophthalmitis ज्यादा spread ना करे. Got it? चलो. Okay. So next is coming over to the chapter of squint. Got it? Okay. I hope it is clear. I hope it is clear. Yes. I hope it is clear. हाँ जी, बताइए, समझ में आ रहा है? एरोप्लेन तो नहीं हो रहा? I hope you are understanding each and important point. That is my idea of giving you very crisp and concise notes. And let me also tell you, in the end, as you all know that I show all my clinical videos, my real patient based videos in my routine lectures, which are 300 plus videos, but the topics which I am taking right now, I have created just 3-minute video of my real patients. In the end, I am going to play to give you a real clinical orientation so that you have a feeling of sitting with me in my OPD and seeing the real patients. Done? Okay, chalo. Now next is coming over to squint. This is again your INI-CT question. So what is this? This is a test of stereopsis. ये क्या है? Guys, this is makhi. Makhi, so this is known as titmus fly test. इसको हम बोलेंगे titmus fly test. So this is your titmus fly test and this is your circle test, just the names. And this is your animal test. Animal test, right? So just a small thing to remember. Of course, makhi lives for 28 days, but some house flies or some flies are good enough to dedicate their whole life annoying other people, है ना? So in everyone's life there is one or two makhi, है ना? But just learn to ignore that makhi, है ना? It may distract you from reaching to your ultimate goal. That makhi can be your good friend. That makhi can even be your special friend who may not be picking up your call, who may not be replying you on WhatsApps. So just ignore that makhi for a while. After clearing the exam, take a bat and tuck, makhi gone. Got it? Chalo, jokes aside. All right. So another test for stereopsis. So one is your RAN.E test. Another is your TN, just the names, TNO test, then Lang test, then Frisbee test. These are 4 tests. Let's just not go into that detail in these tests. Just that these tests are for stereopsis. For stereopsis. Stereopsis means depth perception. And you already know what are the components of binocular single vision. Yes, what are the components of binocular single vision? So there are 3 components of binocular single vision. One is your simultaneous perception. Simultaneous, you already know, simultaneous macular perception. Simultaneous macular perception. Many students are getting happy knowing about what you have to do with that makhi. So this happens when you are nothing. No one will come to you. But when you are something, everyone will try to come to you and try to associate with you. सबके साथ होता है यार. If you are thinking it is happening only with me, only with you, or it has happened only with you, let me tell you, it happened with me only. Me as well. So that's okay. You have to keep that makhi aside. Focus on your goal. Crack the PG entrance exam. Then that makhi will automatically come like gud ke upar makhi. And then it will be your call whether you will just forgive that makhi or you will just shoo that makhi away. Because once you will get into your PG college, then there will be a lot of makhis around you. Maybe queen bees around you. Got it? Okay. You are intelligent enough, yaar. One of the best batches. Done. Okay. So simultaneous macular perception. Second is fusion. Third is stereopsis. So guys, please understand, first 2 things are detected via synaptophore, while third is, I have told you, titmus fly test, circle test, animal test, Frisbee test, Lang test, TNO test. Got it? I hope you have understood. So synaptophore is used for first 2 stages of BSV. It is binocular single vision. Got it? चलो आगे चलते हैं अपने लक्ष्य की तरफ धीरे धीरे बढ़ते हुए. All right. So in the following test, which pattern do the patient see in right exotropia? Kaveri, I shooed it away. है ना? चलो. So in the following test, which pattern do the patient see in right exotropia? Now you need to understand. Now focus. एक बार मक्खी को भूल जाओ, एक बार फोकस करो यहाँ पे. देखो फोकस, अभी ये ना हो कि आप अपना फोकस लूज कर दो और फिर बाद में आप मक्खी के पीछे भागो. मक्खी के पीछे नहीं भागना. मक्खी should come after you. Got it? Okay. Now focus here. Yes, everyone. Okay. So in the following test, which pattern do you see in right exotropia? If the patient is having right exotropia, so that means the eyeball has turned outside. When the eyeball has turned outside, so the object which is lying in front of the eye, the focus of that object will not be on the fovea. It will be on the temporal retina. Got it? It will be on the temporal retina. Now, when it will be on the temporal retina, you know that temporal retina is conditioned to interpret the image on the nasal side. So what the patient is going to see? Patient is going to see a light in the center from the left eye, from the fixating eye, but because the right eye has turned outside and the Maddox rod which is placed in front of the right eye is converting the torch light into a vertical line, and that vertical line will be shifted on the nasal side because now that vertical line is falling on the temporal retina, not on the macula, because it is not falling on the macula, so there will not be any fusion. If the patient is having orthophoria or orthotropia, so if the patient is having orthophoria or orthotropia, so there will be light with a line bisecting it. If the patient is having right exotropia, so the patient will see this. If the patient is having esotropia, so the patient is going to see this. But this is just for understanding purposes. Now, if I may ask you, in less than 30 seconds, you have to attempt one MCQ. So how will you remember in exotropia? There is X now. So X means there will be crossed diplopia. What do you understand by crossed diplopia? Crossed diplopia means the object is lying in the front, but the image is shifted on the nasal side, on the opposite side. The pseudo image, the false image will lie on the opposite side. So you call it as crossed diplopia, and it is seen in X. So quickly, just a single mnemonic in exo, there will be crossed diplopia. Got it? Got it? Okay, you want me to explain again? Okay, wait. So what happens is, there's a torchlight coming from the front, right? Now, if I place a Maddox rod in front of the right eye, now from the left eye, I'm going to see the torchlight. Yes. But from the right eye, the Maddox rod had converted this torchlight into a vertical line. If my both eyes are in well alignment with each other, I am going to see the central torchlight with a line bisecting it. This is the condition first. But if I am having right eye exotropia, in exotropia, so the light which is coming from the object through the Maddox rod is not falling on the fovea because the eyeball has turned outside. It is actually falling on the temporal retina. Now temporal retina of the right eye is being stimulated, but the temporal retina, boys and girls, is what is conditioned to interpret the images on the nasal side. So it will send the signal to the brain, okay. This vertical line is not lying in the center. It is lying on the nasal side. So this is how you are going to see this image. Understood? So this is how the patient will see. It is not the doctor. It is about the patient. So if I am having right exotropia, so I am going to see the central torchlight and the line on the nasal side. Got it? Yes, please batao. Got it? Guys, this is right exo. So this is how the patient will see, na? This is how the patient will see. So this is for the right. मैं दोबारा कर रहा हूँ. This is for right. It is not labeled ulta. It is for right. So this is the left. Left is in the center. Right exotropia. So the image has been shifted to the nasal side. So for right eye, the nasal side will be towards left, na? That is what is shown. This is right means right eye. हाँ जी, समझ में आए? यस और नो? जल्दी बताओ. जल्दी. यस, जल्दी. आज वंदे भारत से भी तेज करेंगे. सारे प्लेटफॉर्म छोड़ के सीधा जम्मू से कन्याकुमारी लैंड करेंगे. रास्ते में कहीं नहीं रुकना है हमने. चलो. All right. Now name the following chart. This is also your previous year question. Yes. Now use. So this is used in which squint? Paralytic squint. And this chart is Hess screen chart. Hess screen chart. This is your Hess screen. This is paralytic squint. Now you know, as per Herring's law, one eye will be underacting while other eye will be overacting. So here this eye, so you can see now, this eye is underacting eye, and as per Herring's law, this eye is, can you see the movement? So it is going out of the box. Now this is the dotted box. Can you see the dotted box? Yes. So it is going way beyond it na. So this is your overacting eye. है ना? इसकी डिटेल में हम नहीं जाएंगे. Just you should know that this chart is to differentiate between paralytic and non-paralytic squint, because in paralytic squint, one eye will be underacting due to paralysis, other eye, the second eye will be overacting as per Herring's law, right? As per Herring's law. Anushka, Same in that case, hypertropia, hypotropia. So the Maddox rod will be either upside or either downsides. Why? Because if the patient is having hypotropia, so instead of the light falling and stimulating the fovea, now if the eyeball has come down, so there will be inferior retina which will come to lie in front of the torchlight, and as a result you will see a line above the torchlight. Got it? Okay. Dear Sharda, Amsler grid is something different. Amsler grid is the boxes with squares. So Amsler grid is entirely different. It is entirely different. This is just a screen. Amsler grid, you properly get a grid like this. That is different. So I think my colleague will be covering retina and he will explain probably Amsler grid to you as well, right? Otherwise you can always visit either of ours back to basics where I have explained Amsler grid test. So that is entirely different, right? पूर्वा पानी पीने का टाइम नहीं है, चलते जाना है, सिर्फ रुकना बिल्कुल भी नहीं है, सीधा हम रुकेंगे ऑप्थेल्मोलॉजी खत्म करने के बाद, है ना? चलो ओके, चलो नेक्स्ट इज योर which diplopia, crossed or uncrossed. I have already explained to you. This is a case of right. देखो ध्यान से, it is a case of, so this is the right eye, this is the left eye, right? Now what happens, this left eye has turned inside so that the fovea has moved outside. As a result, in the left eye, the nasal retina is being stimulated, but the nasal retina interprets the temporal visual field. So the image of the object which is lying in the front, that image will be shifted onto the temporal side. As a result, this is your uncrossed diplopia. Why? Because there is no crossing of the false image with that of the actual image. Got it? Got it? Very good, all of you. Very good. So this is your uncrossed diplopia. अच्छा ये बताओ, which nerve palsy would cause this? Simple. So this is what is the position of the eyeball? Position is down and out. So this is a case of third cranial nerve palsy. Why? Because you know third cranial nerve supplies which four extraocular muscles: inferior rectus, inferior medial, medial rectus, then superior rectus and inferior oblique. Now if there is third cranial nerve palsy, only two muscles will be active. One will be superior oblique, which will make the eye go down. Another will be lateral rectus, which will make the eyeball go outside. So that is why the position is down and out in third cranial nerve palsy. Samriti Girin, so you want me to again repeat crossed and uncrossed? Wait, pen down, ध्यान से सुनेंगे. I am here to tell you one thing 1,000 times, provided you will give your full effort. I am also giving my full effort, है ना? It should be a two-way approach, है ना? Pen down. I am going to explain you one more time. Don't worry at all. I am here. जब तक खत्म नहीं होगा तब तक मैं यहीं पे हूँ. Don't worry. Okay. Now you need to understand. If the patient is having right exotropia, if the patient is having, give me 1 second, I'll help you with this. Okay. If the patient is having, so this is the eyeball. If the eyeball is like this, so पहली चीज you need to remember that the retina is not flat. Retina is like a curved screen. It is like a curved screen. If the patient is having right exotropia, so what is happening? The right eyeball has moved outside, है ना? But earlier, the image which was coming, so it was striking at the center of the retina, which is the macula, which is the fovea. Center of macula is fovea, right? But when the eyeball has turned outside, now the fovea has moved inside, but the point of retina which is in front of the light is now temporal retina, but temporal retina is interpreting the image from the nasal side. Similarly, nasal retina is interpreting the image from the temporal side. Similarly, superior retina is interpreting the image from inferior side, and the inferior retina interpreting the image from superior side. When the eyeball has moved outside, so the temporal retina is being stimulated. As a result, the false image will be projected on the nasal side. So that is why I tell you that this is a case of cross diplopia in exotropia. Got it? Yes, got it? I hope you have understood. Okay, chalo. Now, after having done this, muscle causing this movement. Which muscle will cause this movement? Yes, which muscle is going to cause this movement? So, you need to understand right eye is, so it is right eye is elevated in, it is elevated in abduction. समझ पा रहे हो? देखो, right eye is elevated in abduction, while if I talk about left eye is elevated in adduction, right? Now there is a difference. If I talk to you, देखो यहां पे आप बहुत गलती करोगे, इसलिए मैं थोड़ा सा आपका 2 मिनट एक्स्ट्रा लूंगा, so that you are clear with this concept, because every time when the squint questions are asked, there are high chances that you will commit a mistake that I would personally not want, है ना? Okay, now you need to understand, if I generally talk to you about the extraocular muscle movement, so you already know SO4, LR6, rest third, you already know this, है ना? Now this is the chart that I have put in here. So this is general actions of the extraocular muscles. जो SO4, LR6, rest3 is valid only for these 4 muscles. समझ में आ गया? Is it clear? But here the concept is different. Here I am telling you which muscle is elevator in abduction. So पहले the eyeball will have to abduct, then it will have to get elevated. Here you will not mark the muscle which is causing elevation and abduction. Here you will mark the muscle which will cause elevation in abduction. In and there's a difference. So there's a huge concept behind this. For now you just need to understand which muscle is elevator in abduction. Yes, all of you are answering it correct. So here the muscle which will be elevator in abduction will be superior rectus. Wonderful, yaar. I'm so proud of you, right? Now which muscle is elevated in adducted position? So if I talk about elevation in adducted, it will be inferior oblique. Yes. So agar if you don't understand this concept, you will think, okay, they have asked about elevator and abduction, so which one would you mark? You will mark inferior oblique, which is absolutely the opposite of what is the actual answer, है ना? But how will you remember the action of the muscles? Just remember, superior are in tauters, inferior are extauters. I am telling the mnemonic to understand these extraocular muscle actions. Now oblique are abductors, and recti are adductors. ठीक है जी, I hope it is clear. I hope you have understood the difference between elevation in abduction and elevation and abduction. I hope you have understood, है ना? Okay, beautiful, awesome. Chalo, now coming over to this Park 3-step test. Everything is written. Just keep your pen down and listen to what I say, because this is one of the most important concepts, and I can challenge you. If you are an intern, you can ask about this Park 3-step from first year PG. He may also not know it, but the questions are asked, because probably he did not read ophthalmology with that depth and with that concepts, because ophthalmology is one of those subjects which we don't understand much. During my times, I was also not able to understand ophthalmology much, but if you will connect the dots, trust me, ophthalmology is going to be a beautiful cakewalk. Let's start. Okay, if the patient comes to you with right hypotropia, you just need to listen to me. Rest, step 1, step 2, step 3, everything is written. I want you to focus. Okay, so answer to previous question, which answer? So I have given you na. So this is the right eye. Yes, there are some doubts which students are answering. So this is the right eye, this is the left eye. So this will be right superior rectus na. Right superior rectus. This will be left inferior oblique, isn't it? समझ में आया बच्चों? Right superior rectus. Yes. Shack. Yes. Right superior rectus, because abduction and elevation. So first you will abduct the eye, then you will elevate na. So right superior rectus will cause this movement. So right superior rectus, and this will be left inferior oblique. I hope you have understood. Yes, I hope you have understood. I think you are still confusing between elevation and abduction, elevation in abduction. Don't worry, go through back to basics. And you will be able to understand this. Yes. I can still see that some students are getting confused. Please let me know. Yes, in chart, which chart? Which chart? This chart? No, you are confusing. No, you are again confusing, my dear friends. So elevation in abduction is entirely a different action. Don't confuse about which is the primary action, which is the secondary action, that is entirely different. That is the concept, na? Yahi to concept hai. And this happens, see, don't worry, I am going, acha, can you allow me to take 3-4 minutes so that I explain to you the entire concept of this? मुझे 3-4 मिनट और लगेंगे. अगर आप मुझे अलाउ करोगे तो मैं इसको कॉन्सेप्चुअली सब कुछ एक्सप्लेन कर दूंगा. करूं? बताइए, नहीं तो मैं आगे चलता हूं. जैसे आप बोलेंगे भाई, जैसे आप बोलोगे. चलो, मैं समझ गया. ठीक है. ओके. नाउ देखो, देखो, समझेंगे. फोकस, फोकस. देखो, समझो. अब होता क्या है? देखो. So this is the orbit. This is the orbit. This is the eyeball. देखो ध्यान से, फोकसिंग. एक सेकंड भाई, रुक जाओ, रुक जाओ, रुक जाओ भाई, रुक जाओ. कोई यस, कोई नो, कोई यस और कोई नो. 2 मिनट दो मुझे. Give me 2 minutes. देखो. So this is the eyeball. Now what happens is, you know, extraocular muscles, they are originated from the apex of the orbit, right? So what happens is, superior rectus muscle is coming from the orbit and is getting inserted here like this, right? It is getting inserted here like this. So now you can see that there is some angle between the visual axis and some angle between the orbital axis or muscle plane. So this is your MP muscle plane. This is your visual axis. समझ में आया? Orbits are divergent, but the eyeball is not divergent. Eyeball is seeing forward, right? Now, what if I abduct this eyeball and this angle between the visual axis and orbital axis is 23 degree. Now, if I abduct the eyeball to 23 degree and then I will contract the superior rectus muscle, then the only action of superior rectus muscle will be elevation. So that is why I told that the muscle which is elevator in abducted position will be superior rectus. Understood? समझ में आया? समझ में आया? ये देखिए. So this is when you will rotate the eyeball here. So now the visual axis and orbital axis will be in alignment with each other. Then you will contract the superior rectus muscle. It will take the eyeball upwards. Now the muscle which causes elevation in abduction. Bhai, in elevation in abduction. Got it? Okay. I'm sure. Yes. Now I can see all of you have got. All of you have got. Dear recti are adductors because you can see inferior rectus cause adduction, superior rectus cause adduction. This is different from what I am telling you right now. Don't worry. You can revisit the video or you can check out my back to basics. It's just 5-10 minutes and you will understand in a most beautiful way. चलो आगे चलते हैं. Okay, चलो. Now coming on to PARC 3-step test. PARC 3-step test. So what happens is, if the patient come to you with vertical squint, now patient comes to you with right, let's say the patient comes to you with right hypertropia. Now you don't know whether the right eye upside or left eye is downwards, right? Because the patient has come to you with some, with some misalignment of the eyes in vertical position. So you don't know whether right eye is hypertropic or the left eye is hypotropic. Now you need to tell me, if I talk about that you are suspicious whether right eye is hypertropic or left eye is hypotropic. So there can be two things. In the right eye, either right superior oblique is involved or right inferior rectus is involved, because right eye is let's say right eye is hypertropic. That means right superior oblique is not acting because superior oblique takes the eyeball downwards. So that is why the eyeball has gone upwards. Or right inferior rectus is involved because right inferior rectus is damaged. So right superior rectus will pull the eyeball superiorly. Or if I talk about left hypotropia, because I don't know na, but I just know that there is some misalignment of the eyes vertically. So right superior oblique is involved, or right inferior rectus is involved in the left eye. There can be left inferior oblique or left superior rectus which can be involved. Understood? Got it? Okay. Now this is the first step. You just ask the patient to look in the primary position. बिल्कुल सामने देखने का, बिल्कुल सामने. Right? Then you will be able to filter these four muscles, that there is something wrong in one of these four muscles. This is the first step of Park 3-step diagnosis or Park Balchowski test. Second, once you get to know, you filter out these four muscles. Second is, you just ask the patient to look towards the right side or towards the left side in simple terms, right? So you need to see that if there is increase in vertical deviation while seeing on the right side or on the left side. Let's say that there is increased deviation on seeing towards the left side. If I say that when the patient sees towards the left side, there is increased deviation. So that means either there is involvement of right superior oblique because superior oblique is depressor in adduction. If the patient's vertical deviation is increasing on seeing the left side, so that means right eye is going more up when you ask the patient to look towards the left side. When the right eye is moving more up, that means the counter muscle of the right eye which brings it down is not working. So the counter muscle which causes depression in adduction, that is superior oblique. So one muscle you have filtered out in right eye will be right superior oblique, or let's say the right eye is not going upper, the right eye is not going up, maybe the left eye is going down. So in that case, there can be involvement of left inferior rectus, left superior rectus. Got it? Understood? Yes? Yes or no? Please let me know. Please let me know you have understood. So either right eye will go more up or probably left eye will go more down. When the left eye is going more down, so that means what has happened? So there is either palsy of the left superior rectus or right superior oblique. So it is left superior rectus and right superior oblique. Got it? Now this is the second step. Now coming on to the third step. So third step is, you just ask the patient to tilt the head on one side and then to the other side. Now you know that the compensatory head position will always be in the direction of action of involved muscle. I'll give you one example. Suppose the patient is having right lateral rectus palsy. So right side the patient will not be able to see here, right? So compensatory head position will always be in the direction of action of paralyzed muscle. So there will be right head turn so that the patient does not have to use the right lateral rectus much. Understood? Now let's suppose the patient is having right superior rectus palsy. So what is the action of superior rectus? Elevate. Right side elevate. Now, so there will be right sided chin lift. Now coming over to this third step. Suppose the patient is having right superior oblique palsy. What is the primary action of superior oblique? Can you tell me? Boys and girls, this is intorsion. Primary action is intorsion. Check this out. Ye dekho. Primary action of superior oblique is intorsion, right? Now, if you ask the patient to tilt his head, now if there is right superior oblique palsy, so when you will ask the patient to tilt the head onto the right side, now to compensate for this right sided head tilt, the right eye should intort. But boys and girls, this right eye cannot intort because superior oblique is paralyzed and the primary action of superior oblique is intorsion. So it cannot intort. As a result, the patient's diplopia will increase. But what if you ask the patient to tilt his head onto the left side, and you know the compensatory head posture will always be in the direction of action of involved muscle. So when you ask the patient to tilt his head onto the left side, so the patient's diplopia will improve because right superior oblique cannot intort, and you have asked the patient to put the head in left tilted position, so right eye is automatically intorted, so the eyeball does not need to do any intortion. So in that case, the patient's diplopia will improve. So this will tell you. So we started with 4 muscles, then we got down to 2, then finally on the basis of head tilt we got down to 1 muscle, which is superior oblique in this case. Got it? Chalo. Okay. Now next is last topic of sprint. What is this? So guys, this is your nystagmus. Nystagmus कितने प्रकार का होता है जी? Nystagmus, one is your physiological and another is pathological. Physiological nystagmus, one is optokinetic nystagmus. This is your optokinetic drum. Optokinetic drum. So this is physiological optokinetic drum, number 1. Second, have you ever heard of something known as vestibular nystagmus? Deepak sir must have taught you the vestibular nystagmus. Cows, cold water, opposite side nystagmus, warm water, same side. So you call it as vestibular nystagmus. I am talking of physiological nystagmus, my dear boys and girls. And third is your end gaze nystagmus. End gaze. What is end gaze nystagmus? End gaze is if I am looking towards the object on the end like this. So when I look on the extreme end, so there will be small nystagmus which will happen. This is physiological. So these are 3 forms of physiological nystagmus, and then there can be pathological nystagmus. One important pathological nystagmus is ataxic nystagmus, which has been asked many times. Ataxic nystagmus, which is seen in internuclear ophthalmoplegia. Internuclear ophthalmoplegia. That is one your previous year question. I don't want to leave even a single PYQ or PYT out of the topics which have been allotted to me. So this is one very, very important. So ataxic nystagmus, internuclear ophthalmoplegia. Second is seesaw nystagmus. Seesaw nystagmus. It is seen in chiasmal lesions. Chiasma lesions. Very good. Internuclear ophthalmoplegia is due to medial longitudinal fasciculus lesions. Very good. Very nice. MLF lesions. Right? Okay. चलें आगे. Squint को अब खत्म करते हुए. Let's switch over to our next topic. So we are almost on the verge of ending the session. चलो चलें आगे. Yes. Boys and girls. Done. बताओ समझ में आ रहा है भाई? I hope everything is not getting aeroplaned. ऐसे नहीं होना चाहिए. हाँ जी, are you all understanding? चलो, next is coming over to cornea. All right. Next is coming over to cornea. A 30-year-old male has a history of prolonged contact lens wear, develops redness and he ignores it. बहुत लोगों के साथ ही होता है ना? Okay. Then later after a month he visits IOPD with this condition. What is this बच्चों? This is your corneal ulcer. Cornea ulcer. Now if we talk about corneal ulcer, which is the most common etiology, most common organism responsible for corneal ulcer in patients with contact lens, it is Pseudomonas. Very, very important. This is your previous year question. Pseudomonas. But if the examiner wants to ask which is the most common etiological agent responsible for corneal ulcer, in which there is a history of swimming in pond, if there is history of swimming in pond, number 1, or contact lens, or history of contact lens washing in tap water, then it is not Pseudomonas बच्चों, then it is your acanthamoeba. Acanthamoeba. It is your acanthamoeba. So these are two important MCQs. Acha. So causative organism I have told you, diagnosis I have told you, complications. If I talk about complication, what happens is that there is repeated sloughing of the superficial layers of cornea. And which layer is the strongest layer of cornea? It is Descemet's layer. So here, due to repeated sloughing of the superficial layer, this is the shiny bulging layer. This is your previous year question. What is this? So due to superficial sloughing of the layers, due to intraocular pressure, there is a bulge in the strongest membrane, which is Descemet's layer. You call it as descemetocele. You call it as descemetocele. Now what is this? Now eventually when the patient will strain, cuff or lift heavy weight, it is going to rupture the descemetocele. It will lead to perforated corneal ulcer. It will lead to perforation. It will lead to perforation. Done? Okay. Now you need to understand another concept I am giving you, because most of you students have a tendency to do it wrong. Now when there is perforation, so there is sudden deflation of the eyeball. When there is sudden deflation of the eyeball, what happens? There is extravasation of the aqueous humor from the eyeball. There is sudden collapse of the anterior chamber. As a result, the iris will come and get stuck at the back of the cornea. When the iris will come and get stuck at the back of the cornea, but the aqueous humor is constantly being produced. When the aqueous humor is constantly being produced, now the hole which was created in the cornea after perforation has been plugged by the iris. So the intraocular pressure will again try to become normal because the hole has been plugged. As a result, there will be bulging in the whole part of the cornea, and you will call it as staphyloma. Why staphyloma? Because after perforation, there was plugging of the perforation with that of iris, and you know the limbal stem cells, which are known as palisades of Vogt, which lie at the limbus. Limbus is sclerocorneal junction. They will move and try to cover the hole which is plugged by the iris. So the epithelial palisades of Vogt will try to cover the superficial layer of the iris which is plugging the hole, and due to raised intraocular pressure, there will be bulging of that epithelium layer which will be formed on the surface of the iris. That bulging of the epithelium layer, so that epithelium layer is not actually the true cornea, it is pseudocornea. Why pseudocornea? Because cornea consists of how many layers? A, B, C, D, E, from anterior to posterior: anterior epithelium, Bowman's membrane, corneal stroma, then Dua's layer, then Descemet's membrane, then endothelium. But this epithelium is the only layer of cornea which is left and plugging the hole with the iris backwards, है ना? So this will lead to what? This will lead to pseudocornea, and this bulging of pseudocornea you call as staphyloma. So what is the exact definition of staphyloma? So exact definition of staphyloma is ectatic, means ectasia, ectatic cicatrix with iris tissue incarceration posteriorly. Iris tissue क्यों बोला? Because we are talking of anterior staphyloma. This staphyloma can be intercalary, it can be ciliary, it can be even posterior, right? I am talking of just the sequelae of corneal ulcer perforation. Ectatic cicatrix with iris tissue incarceration posteriorly. तो इसको हम क्या बोलेंगे? Typically we call it as anterior staphyloma. Now you will say, sir, anterior staphyloma is this. There can be posterior staphyloma as well. Posterior staphyloma. Now your previous year question, posterior staphyloma means there is bulging of the outer layers of the iris behind the ciliary body. So posterior staphyloma is most commonly seen in high myopia. This is your previous year question. See, either yes, Abhishek, I am coming upon this. I know this is the most burning question of your life. जब तक इसका आंसर नहीं मिलेगा शायद आप पूरी जिंदगी नहीं सो पाएंगे, ये सबके साथ है. सो डोंट वरी, आई एम गोइंग टू कम अपॉन दिस, बट फॉर दैट आई नीड टू बिल्ड योर कॉन्सेप्ट ना. आई जस्ट डोंट वांट टू डू एवरीथिंग इन अ रैंडम वे. आई नीड टू बिल्ड योर कॉन्सेप्ट सो दैट यू आर एबल टू कनेक्ट द डॉट्स, है ना. आई होप यू हैव अंडरस्टूड डियर अभिषेक अबाउट एंटीरियर स्टेफाइलोमा, है ना. दिस इज एक्टेटिक सिकाट्रिक्स विद आइरिस टिश्यू इनकार्सरेशन, है ना. समझ में आया. नाउ इफ दिस आइरिस टिश्यू, नाउ सी, नाउ द नेक्स्ट क्वेश्चन. सो दिस इज द eyeball. Now this is the eyeball. If there is iris tissue incarcerated here, anywhere here, you call it as anterior staphyloma. If it is here in the limbus, at the limbus, you call it as what? You call it as intercalary staphyloma. Intercalary. Now if it is in the region of, what is this? This is ciliary body. So you call it as ciliary staphyloma, right? In the ciliary body region, there will not be iris, there will be ciliary body, which is the part of uvea. But if it is posterior to ciliary body, if it is posterior to ciliary body, you will call it as posterior staphyloma. Now in posterior staphyloma, if it is specifically at the equator, you can call it as equatorial staphyloma. समझ में आ गया इतना? समझ में आ गया ना? Okay. Now there is a difference between scleromalacia perforans, right, and staphyloma. Just one single line answer. You have understood na staphyloma. Staphyloma is ectatic cicatrix, which is bulging with uveal tissue incarcerated. If it is on the anterior side, iris will be there. If it is at the intercalary, of course, limbal, there will be uveal tissue. If it is at the ciliary level, so ciliary staphyloma. If it is posterior level, then there will be choroid, hai na? Now, the difference between scleromalacia perforans and staphyloma is, in scleromalacia perforans, it is just the thinning of the sclera. No bulging. No bulging. But in staphyloma, there has to be bulging. So here you see bulging. So this is your staphyloma. Yes. And here there is no bulging. So this is your scleromalacia perforans. I hope this concept is crystal clear now. Very good, Divya. Yes. And scleromalacia perforans is due to the antibodies which are formed against the sclera, due to which scleral melt happens, right? And it leads to thinning of the sclera, right? Understood? Okay, wonderful. Now coming over to our next case. A 50-year-old farmer visits IOPD with history of injury. Ye dekho how the cow's tail is feeling proud of inflicting the injury, right? This actually happens. When I was in OPD like 2-3 months back, I actually received a patient who had a history of hitting the eye with cow's tail while milking the cow, right? So this happens. So what is this? Yes, characteristic feature. So this is your characteristic feature. What will be the margins? Non-defined margins. Non-defined margins are there. Number one. What is this? This is your satellite lesion. Your previous year question, satellite lesion. So what is this? This is your hypopyon. Now please understand, in fungal keratitis, the hypopyon will be sterile or non-sterile? It will be non-sterile and fixed. Non-sterile and fixed. Plus there will be presence of Wesley's immune ring. There will be presence of Wesley's immune ring. Wesley's immune ring is antigen-antibody reaction at the junction of normal cornea and infected cornea. Got it? Okay. So what will be the treatment? Just one liner. Repeated questions. If the infection is by branched fungus, or in other words you can say fungi, branched fungus, so it will be netamycin. Unbranched fungus, yes, लिखेंगे मेरे साथ, unbranched fungus, so it will be nystatin. But new generation antifungal is voriconazole. These are 3 MCQs which are covered. Voriconazole, this is your new generation. New generation antifungal. Done. 3 MCQs down. Okay. Now coming over to the next lesion. Identify the lesion. What is the stain used? So what can you see here? So this is which stain, boys and girls? You already know it. Your NEET PG 2023 question. There was a stain which was asked. So this is your fluorescein stain. Fluorescein stain. What is the color of fluorescein stain? The color is orange. The color is orange. So it absorbs blue light. It will absorb blue light. It will absorb blue light and it will emit green light. It will emit green light. It will emit green light. And this is a clear-cut case of dendrites. So what is this lesion? This is your dendritic keratitis. Dendritic keratitis. Very good, very good. So no, dear Akul, this is not herpes zoster. These are dendrites. So dendrites, you have got knobbed lesions, knobbed endings. So this is seen in herpes simplex virus keratitis. This can be asked as a spotter. As a spotter, image-based question, very high chances. It has been repeated many times in your previous year examination. Done? Okay. Now coming on to next, what is this? This is a pseudodendrite. This is a pseudodendrite, and here you don't have knobbed ends. You just have like this. The lesion is just like this. So no knobbed ends. Yes, cobalt blue. It absorbs cobalt blue light, which is the light of shorter wavelength, and it emits green light, which is a light of longer wavelength. Got it? Yes. Got it? Yes. Dragon. Okay. Order of staining, I am coming to that in a while. Don't worry. By the way, very nice ID. Dragon. Okay, wonderful. Okay. Now, what is this? So, pseudodendrites are typically seen in herpes zoster ophthalmicus. Now, guys, please understand, herpes zoster ophthalmicus is not due to herpes simplex virus. Herpes zoster ophthalmicus is actually varicella zoster virus, which is your chickenpox virus. Don't confuse कि sir herpes तो दोनों एक ही virus है. No, it is due to varicella zoster. It is due to varicella zoster virus, which is actually your chickenpox virus. So अगली बार अगर आप CPR दे तो थोड़ा सा ध्यान रख लेना, है ना? चलो, wonderful. Now what is this lesion? This is your Hutchinson sign. This is your Hutchinson sign. What is your Hutchinson sign? Hutchinson sign states, Hutchinson rule or Hutchinson sign states that if there is involvement of the tip or side of the nose, there will definitely be involvement of the cornea. Why? Because of the same nerve supply. And what is that nerve? What is that nerve? Yes, boys and girls, what is that nerve? Very good. Who is the first one to answer? Okay, किसने बोला? Yes, Bhavya, very good. So this is your nasociliary nerve. Nasociliary nerve. Very good. Nasociliary nerve supplies the tip of the nose and the cornea. Okay, done. Now coming over to next question. A 21-year-old with decreased vision, frequent change of myopic glasses. Now I am going to give you 2-3 important MCQs. Now, if there is old patient plus frequent change of myopic glass, what will be the answer? Yes, old changes, old patient with frequent change of myopic glass, you will suspect cataract. But young patient with frequent change of myopic glass, you will suspect keratoconus. I am going to give you another important question. So if there is patient with frequent change of presbyopic glasses, so this was 1, this is 2, this is 3. Presbyopic glasses, frequent change of presbyopic glasses. So you will mark open angle glaucoma. Very good. Open angle glaucoma. Open, dear Dega Hemnath. So index myopia you will be doing in your lens chapter, right? Okay. So we are currently talking of cornea. Okay. All right. Open angle glaucoma. Open angle, Pooja Kumari, good morning. Okay. So don't worry, you'll get the recorded version of this. Okay. So presbyopic glasses, open angle glaucoma. There is another question, which is the condition in which there is fluctuation of myopic glasses. I am not talking of increased number of myopic glasses. I am just talking of fluctuation of myopic glasses or fluctuation of myopic power. So that will be your diabetic mellitus. Diabetic mellitus. Diabetic second is young patient with decreased vision and frequent change of myopic glasses. You will have a suspicion of keratoconus. Old patient with frequent change of myopic glass, it will be cataract. Then there will be a patient which will have a frequent change of presbyopic glasses, that will be open angle glaucoma. Done. And fluctuation of myopic power, it will be diabetic mellitus. Done. Okay. Okay. Now what are the important features that you see in keratoconus? So what is this? What can you see? What is this? This is your Fleischer ring. What is Fleischer ring, boys and girls? Fleischer ring is actually iron deposition. This is iron deposition on the corneal epithelium. On corneal epithelium, and it is seen at the base of keratoconus. It is seen at the base of keratoconus. Got it? Please don't confuse Fleischer ring with that of, यहाँ पे box बना के लिख रहा हूँ, with that of, you already know, KF ring. It is Kayser-Fleischer ring. It is Kayser-Fleischer ring. Guys, please understand, this is actually copper deposition in which layer? In Descemet's membrane of cornea. In Descemet's layer of cornea, and it is seen in more commonly Wilson's disease. But एक चीज का ध्यान रखना, your previous year question, KF ring is actually depicting the response to therapy. This is reversible. KF ring is reversible and it depicts the response to therapy. Every single line that I am telling you is your previous year question. 2020 INICT 2020 जो पहला INICT हुआ था, which happened to be in COVID, उसमें there was one option, KF ring is reversible, and the question was which of the following is incorrect. So most of the students mark KF ring is reversible. This is actually correct. So it also tells you about the response of therapy. Oh bhai, zinc nahi hai chacha ji. It is not zinc, it is copper. Response to therapy. It is response to therapy. Got it? Okay. So that was KF ring. Now next feature of keratoconus is there will be what? There will be, can you see that the Myers are irregular? Irregular Myers. So Myers are irregular. Myers are irregular. So these are what changes? These are topographic changes of the cornea. Topographic changes of the cornea. What is this sign next? Yes. What is this sign? Can you see the V which is formed? So what you do, you ask the patient to look downwards, and when there is protruded cone of keratoconus, when it goes behind the upper eyelid, behind the lower eyelid attains the V-shaped pattern. This V-shaped pattern is known as which sign? Yes, very good, very good, very good. This is your Munson sign. This is your Munson sign. Got it? This is your Munson sign. Done. Okay. Now what is this? What are these? These are your prominent corneal nerves. Prominent corneal nerves. These are all the features that you see in keratoconus. Okay. Now moving ahead. What is this? This is your oil. Yes, yes. Jaldi batao. Oil drop cataract का नाम सुना है? Oil drop cataract is seen in galactosemia. Right. Now next is oil drop reflex. Oil drop reflex is seen in keratoconus. Don't confuse oil drop reflex with that of oil globule reflex. हाँ जी बताइए, don't confuse. Oil globule reflex is seen in anterior lenticonus. देखो, I am trying to link all the important things because in the end you should be able to revise almost everything in a very, 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 very short duration. That is my idea, है ना? So don't confuse, है ना? Now I have put up all the important signs. So Munson sign, topographic changes, walk striae. What are walk striae? These are vertical striae due to tears in the Descemet's membrane. Due to tears in Descemet's membrane. So these are vertical tears. Don't confuse vertical tears with that of horizontal tears which are half striae. These horizontal tears are half striae, and this is seen in congenital glaucoma. How will you remember? H for halves, H for horizontal, H for half, H for horizontal, V for walked and V for vertical. समझ पा रहे हैं? देखो, I am trying to link all the things, so don't get this wrong, right? Next is Fleishering. We have already done hydrops because there is tears in the Descemet's membrane. Because there is tears in the Descemet's membrane, as a result, it will lead to aqueous humor coming in the stroma, and that can lead to hydrops. Hydrops means edema of cornea. So it is edema of cornea. Next is Caesar reflex. So when there is cone of keratoconus, you pass the vertical beam of light from one side to another side. The moment it will come to lie over the cone of keratoconus, it is going to split into two, and then it is going to split into two and then again rejoin. Split into two, again rejoin. Something like moving arms of the Caesar. That is why you say that it is a Caesar reflex. Done? Got it? Okay, oil drop reflex, my dear Azam ji, is seen in, yes, बताइए, oil drop reflex is seen in keratoconus. Oil drop reflex. Don't confuse oil drop reflex with that of oil globule reflex that is seen in anterior lenticonus. ठीक है जी, चलो. Now, what will be the treatment? Okay, this is one of the most cheesy pickup line, है ना? Okay. ठीक है, कितने लोगों ने ट्राई करा है? और इसके बाद कितने लोगों को इसके बाद ब्लंट ट्रॉमा रिलेटेड कैटरेक्ट मिला है? रोजेट कैटरेक्ट मिला होगा, है ना? चलो कोई नहीं, लेट्स जस्ट नॉट गेट इनटू दैट. ओके, नाउ व्हाट विल बी द मैनेजमेंट? फर्स्ट एंड फॉरमोस्ट विल बी रिफ्रैक्शन. रिफ्रैक्शन. सो रिफ्रैक्शन का मीनिंग है यू विल आस्क द पेशेंट टू गेट द ग्लासेस. बट ये हमारी पापा की परी है, इनको बोला गया भाई यू नीड ग्लासेस, बट इनका ध्यान कहीं और ज्यादा चला गया, ये कोई और ग्लासेस की तरफ. भावनाओं 8 बजने वाले हैं ना, तो 8 जैसी जैसी बचते हैं ना, वैसे वैसे ध्यान बिल्कुल ध्यान जो है वो अनंत सुख की तरफ बढ़ने लगता है. और उसके बाद अगर हम ग्लासेस बोलें तो ये जो ग्लासेस हैं वो कुछ और ग्लासेस ही नजर आने लग जाते हैं. बट एनीवे, आई मेंट रिफ्रैक्शन वाले ग्लासेस, दीज ग्लासेस, नॉट दैट दोज ग्लासेस, है ना? ओके, नाउ नेक्स्ट इज rigid gas permeable contact lenses. These are made up of PMMA. This can also be given. Okay, now next is which is the best treatment which is available? That is C3R, which is corneal collagen cross linking with riboflavin. So that is C3R. It is the most commonly done treatment. So this is best treatment nowadays which is available. Next you can try Intex, which is intrastromal corneal segments. So these are intrastromal segments which are made up of polymethyl methacrylate. मैं full form लिख रहा हूं, polymethyl methacrylate, polymethyl methacrylate, right? So these are two segments, semicircular. You put from one side and another side, it will stretch the cornea such that the cone of keratoconus will go down. Okay. Okay, dear Guddu Pandit, the irregular Myers are that you will do a placido disc examination, and when you will look out for the image of the circles in the placido disc as a reflection on the cornea, because there is cone in the center of keratoconus, the Myers, the circles are very irregular. So normally in the cornea, any image you will see like this, है ना? Right? But if the patient is having keratoconus, you are going to see the circles like this. So you call it as Myers because the cornea is very uneven, right? Okay, I hope you have understood. Okay, okay ji, okay, not using green color, okay, fine. Okay, rigid lens is made up of PMMA, polymethyl methacrylate. Okay, chalo. Now keratoplasty, what is keratoplasty? Keratoplasty is simple corneal transplantation because here the cornea is not healthy, there is keratoconus, so you would go for replacement of the cornea in keratoconus. So that is a keratoplasty. Now if I talk about keratoplasty, this can be penetrating keratoplasty, which is full thickness keratoplasty. So here you can see that the sutures are applied. This is your previous year question 10O. Nylon sutures are preferred on the cornea, I have already told you. And please understand, in keratoplasty, only organ in the body in which HLA typing is not required. HLA typing is not required. I repeat, HLA typing is not required. Okay, all right. So keratoplasty is very important. One is full thickness, you call it as penetrating keratoplasty. Another is your lamellar keratoplasty. Another is lamellar keratoplasty, which is partial thickness. Just the terms. Keratoplasty, which is partial thickness keratoplasty. Partial thickness keratoplasty. Cornea is avascular, so HLA typing is not required. So first is your full thickness, which is penetrating. Another is lamellar, which is partial thickness. And you can see the sutures can be of two types. One is interrupted sutures. So the sutures are interrupted sutures, or the sutures can even be, Anushka, the treatment of choice is C3R, best treatment, I told you, na. So this is what? This is my real patient's cornea, and these sutures are continuous sutures. Continuous sutures. Continuous sutures. So these are done in penetrating keratoplasty. In partial keratoplasty, what you do, suppose the patient's epithelium is damaged. So epithelium or stroma is damaged. So you just transplant epithelium and stroma of the graft cornea to the host cornea. So you cut the cornea into halves, in which you remove the defective epithelium till stroma, and then you replace it with grafts, epithelium and stroma. Got it? Okay, done. Next is your LASIK. LASIK is the surgery in which you want to remove your glasses, but important thing is that you can correct myopia up to 12 diopter. Your previous year question, you can correct hypermetropia up to 4 diopter, and you can do astigmatic correction up to 3 diopter plus minus. So what do you do in LASIK surgery? So you actually cut the cornea so that a flap is made. So this flap thickness is 160 micron, just for basic understanding. So this is 160 micron, and the stroma is exposed. When the stroma is exposed, you ablate the stroma so that the net thinning of the stroma happens. Then you replace the flap. So you go for laser sculpting, and as a result, the final curvature will be flatter. And because the final curvature is flat, so the power of the cornea is reduced, and you know power is inversely proportional to focal length. When the power is decreased, the focal length is increased. So the image which was previously being projected in front of the retina will shift over to the retina. That is the principle of LASIK surgery. Got it? Okay. Now coming over to next, which is conjunctiva. So what is this? There's a patient with redness, watering, foreign body sensation, photophobia, pre-auricular lymphadenopathy. हाँ जी बताइए. This is a case of pink eye, which is the most common organism. Your previous year question. This is, of course, pink eye. The other name of pink eye is epidemic keratoconjunctivitis. Epidemic keratoconjunctivitis, and this is caused by adenovirus most commonly adenovirus. This is caused by adenovirus. Now what is this? This is your hanji acute hemorrhagic conjunctivitis. Can you see subconjunctival hemorrhages? And the most common etiology is your previous year question, enterovirus 70. Entero, if this is not in the option, you can go for Coxsackie A24. But both viruses are included in one group. What is that one group? That is picoRNA virus, right? But most common remains enterovirus 70. Second most common Coxsackie A24. Done? Okay. अच्छा, एक चीज का ध्यान रखना, जो LASIK सर्जरी है, if we talk about LASIK surgery, it is usually not done in boxers, because you have replaced the flap. Now, if the patient had LASIK surgery and suddenly a punch comes, there can be chance of dislocation of the flap. So it is not preferred. It is not done in boxers because of chances of dislocation. Yes, because of chances of dislocation of flap, because it takes time for the flap to settle down. Now, that is also your previous year question. Okay, now there is a patient who is newborn, age 7 days. Following features are seen. Herbert pits. Yes. Can you see these small pits? These are Herbert pits. Now, what is the condition? Herbert pits are there. This is your pannus, progressive pannus. So progressive pannus is when the infiltration is ahead of vascularization. So there is regressive pannus. What is regressive pannus? Regressive pannus is when the vascularization is ahead of infiltration, or you can say infiltration is behind vascularization. So that is your regressive pannus. So अभी तक आपको disease तो पता लगी होगी. What is this? This is your trichiasis. All are your previously asked image based question. Trichiasis is misdirected eyelashes. Misdirected eyelashes. It is misdirected eyelashes. What is this? This is tylosis. Tylosis is thickened. It is thickened tarsal plate. Thickened tarsal plate. These are the images that I have specifically added. So that you are able to pick up the image based questions. Very good, very good. You already are answering very beautifully. What is this? This is entropion. This is entropion is inward rolling of eyelids. Inward rolling of eyelids. Okay, inward rolling of eyelids. I hope it is fine now, Shruti. Now what is this? This is your Arl's line, your previous year question. This is your Arl's line. Arl's line is fibrotic line on upper palpebral conjunctiva. It is fibrotic line. Fibrotic line on upper palpebral conjunctiva. Don't confuse Arl's line with that of Arl's triangle. Arl's triangle is due to arrangement of keratic precipitates in uveitis. Got it? Okay. What is this? This is falling off eyelashes, जिसको हम बोलेंगे madarosis. Madarosis is falling off eyelashes. Don't confuse madarosis with that of poliosis. Poliosis is graying of eyelash. Graying of eyelashes. Now you already know which disease I am talking of. I am talking of one disease which is your trachoma. I want to give you two previous year questions in trachoma. One, which is the diagnostic sign in trachoma. It is presence of bulbar follicles. Bulbar follicles is the diagnostic feature. Boys and girls, yes, diagnostic feature of trachoma first. Right? And what is the age at which trachoma happens? If the age of the newborn is more than or at least equal to 5 days and the patient is giving, of course, patient to बहुत छोटा होगा. If the patient's father, mother or attendant is giving a history of having the features of trachoma after 5 days of birth, you will simply think of chlamydia trachomatis. So the age at presentation should be more than 5 days and patient should give history of developing signs and symptoms after 5 days. Okay, prevention strategy क्या करते हैं? Safe strategy is done. As for surgery, if I talk about surgery for which disease? Your previous year question 2021 November INICT exam. It is done for trichiasis. If this is not in the option, then you will go for entropion. Antibiotic prophylaxis. कौन सी antibiotic दोगे? Your previous year question azithromycin 1 gram. 1 gram stat. 1 gram is both therapeutic and treatment. Therapeutic and prophylactic. Right? Prophylactic. Done. And if I talk about facial cleanliness, of course you will go for facial cleanliness, and environmental sanitation is also important. Next, when you will go for safe strategy? You will go for safe strategy if there is presence of bulbar follicles, because you know na, if there is presence of bulbar follicles, so you know that it is nothing but trachoma. Bulbar follicles in the age group of 1 to 9 years, if it is more than equal to 10%. So if you take 100 children in the community from the age group 1 to 9 years, if 10 or more are seen with the presence of bulbar follicles, you will think of safe strategy. And you know azithromycin is drug of choice. Azithromycin, drug of choice. Okay, now coming on to next. Okay, male teenager visits IOPD with parents complaint of itching in both eyes, which is more in summers. Boys and girls, this disease is more in summers, but this is known as spring catarrh, which is misnomer, right? Now what is this? You can see this is your cobblestone papillae. देख पा रहे हैं? This is your cobblestone papillae, and don't confuse Herbert Pitts with that of Horner-Tranta spots. Horner-Tranta spots. So you can see Horner-Tranta spots. And what is this? This is your pseudogerontoxon. Pseudogerontoxon. And there can be another feature that you see in this. This is a case of vernal keratoconjunctivitis. Which case? This case. See these three images. This is a case of vernal keratoconjunctivitis. So pseudogerontoxon is there. This is your type 1 plus type 4 hypersensitivity reaction. If this is not in the option, go for type 1. If this is also not in the option, go for type 4. This is the sequence because most of you students get confused. And also to remember, there is one important sign which is Maxwell-Lyon sign. Maxwell-Lyon sign is thick ropey discharge. It is thick ropey discharge with eosinophils. That is very, very important sign. These are important features, and you should know in vernal keratoconjunctivitis, it is more common in males, bilateral condition, teenagers. And what will be the treatment? You will go on, don't give steroids. You will go on for antihistaminics. Olopatadine is drug of choice. If olopatadine is not in the option, you will go for mast cell stabilizer. Mast cell stabilizer, and that is your sodium chromoglycate. Sodium chromoglycate, dear Mudra. So basically, you need to have the history. If the patient is presenting to you with a history of contact lens wear, and the patient is not a teenager, है ना? So you will think of giant papillary conjunctivitis, because clinically it may be really difficult to differentiate between giant papillary conjunctivitis and giant papilla and cobblestone papilla. So you will take the history, because in vernal keratoconjunctivitis it will be more in summers, but for contact lens induced GPC, giant papillary conjunctivitis, it will be present all the time. Number one. Second, it will be more common in males, but contact lenses are mostly worn by females more often, right? So it will give you a clue. So you need to take the history just on the basis of papilla. You cannot tell whether it is GPC or VKC. I hope you have understood. Okay, done. Now next is, what is the difference between scleritis and episcleritis? It is one of the most important and conceptual part to know. So if I talk about the layers of the eyeball, first we have got conjunctiva, number 1. Second, we have got Tenon's capsule, outside to inside, Tenon's capsule. Third, we have got what? Sclera. There are parts of sclera. We have got episclera, and then I have got sclera proper. I need to explain you this before telling you about the difference, because it is important to learn this conceptually. And third, from outside to inside, we have got lamina fusca. समझ में आया? Lamina fusca. I am telling you about the layers in the eyeball. Fourth, then we have got choroid from outside to inside. Then fifth, I have got retina. Now, what is episcleritis? Episcleritis is not a different layer, boys and girls. Episcleritis is a part of sclera only, but this is the superficial layer of sclera. So this is episcleritis. And if I talk about scleritis, it is just the inflammation of sclera proper. समझ में आया? So don't think episclera is a magical sheath which has come from heavens. No, episclera is a part of sclera only, right? So what will be the difference? Because episclera is superficial, so there will be blanching on putting phenylephrine eye drops. But sclera is deep, sclera proper is deep, so there will be no effect of putting phenylephrine drop. Number 1. Episcleritis is involving just the superficial layer, no pain. In sclera, it is involving deep layer of sclera, middle layer, so there will be pain, right? And sclera is associated with collagen vascular disease, while episclera, it can be idiopathic. Most common is idiopathic. Got it? Fifth is retina. Fifth is retina. Fifth is retina. I hope you have understood. This is from superficial to deep, conjunctiva, Tenon's capsule and so on. Got it? Okay. Acha ye, okay. This, okay, I've got it. Sorry, so sorry. So what is this? This is your pterygium. I'm so sorry, I missed it. Pterygium. This is your pterygium. This is the elastotic degeneration of conjunctiva. Sorry. Chalo, aage chalte hain. What is this? What is this? This I wanted to let you know. This is your Stocker's line. What is Stocker's line? This is again iron deposition. This is iron deposition just ahead of pterygium on corneal epithelium. Cornea, epithelium. These are the two things I wanted to let you know. That is why I had put these two images. And pterygium is elastotic degeneration of conjunctiva. I hope you have understood. I hope you have. Yes, very good. Very good. Wonderful, Shambhavi. Very good. Okay. So iron deposition done. So we are done with these two images. Now you can see that there is blanching on putting phenylephrine drops. है ना? Phenylephrine डाल रहे हैं. Phenylephrine drops. There is blanching. Okay. Now coming over to xerophthalmia. This classification is very important. One question has come. Bitot spots, which are foamy spots present on the temporal conjunctiva. More commonly, they are seen in which stage of xerophthalmia? X1b. Bitot spots. They are having foamy appearance. Just one liner. Foamy appearance. Now what will be the treatment of xerophthalmia? So you will give vitamin A palmitate. Vitamin A palmitate. You can give orally or you can even give intravenous. So if you want to give orally, age is less than 6 months. If age is 6 months to 12 months. And age is more than 12 months. So there are three conditions. First is if the age is less than 6 months. So you are talking of giving it orally. So you will give 50,000 international unit. Then you will give 1 lakh international unit. Then more than 12 months you will give 2 lakh international unit. But you know, if you are going to give intravenously, so there'll be more bioavailability. So intravenous is oral divide by 2. Simple. Done? Yes. Done. So intravenous is oral divided by 2. Okay. Now coming on to staining. Please understand, in a recent exam, a question was asked, what is the sequence of staining in dry eye? समझेंगे, ध्यान से conceptually समझेंगे. Sequence of staining in dry eye. Now if we go by the classification of dry eye, which is xerophthalmia. ध्यान से देखो, concept बता रहा हूं यहाँ पे. कोई और पूछ भी रहा था chat में. So sequence of staining in dry eye. So what is the classification of dry eye? First and foremost, which drying is happening? That of conjunctiva or cornea? जल्दी बताओ. It is conjunctival xerosis, na? Conjunctiva. Then there is involvement of cornea, na? So that means first there will be conjunctiva, then there will be cornea. This is one, because I believe that there was some problem in the recall of this question, but I am going to give you both the scenarios, then I am going to explain to you. Conjunctiva and cornea. Now you also need to understand which is the best dye to stain conjunctiva. For conjunctiva, there can be rose bengal and there can be lissamine green. These are two dyes which are used to stain conjunctiva more commonly. And for cornea, this is for conjunctiva most commonly. And for cornea, we have got fluorescein dye. समझ में आया? Fluorescein dye. Now, if we go by the classification, so there has to be rose bengal and lissamine green ahead of fluorescein dye. So they should be preferred. But out of rose bengal and lissamine, you just need to understand that rose bengal has more stinging than lissamine green. So out of rose bengal and lissamine green should be preferred. If we talk about conjunctival staining with respect to the usage of dye, it should be lissamine green because it is relatively less stinging than rose bengal, than fluorescein dye. This is one. Another recall can be, what is the usual dyes which are most commonly used in staining in dry eye? One is, what is the correct sequence of usage of dyes? Second is most commonly used dye. There is a difference. If we talk about most commonly used dyes, most commonly, because fluorescein dye is available most commonly. So then it will become fluorescein dye, then lissamine green, then rose bengal. I hope you have understood that. So there are two schools of thought. So I have given you now, if the question is repeated, so you need to see if they ask most commonly used dye sequence. So then of course fluorescein, then lissamine green, then rose bengal. If they ask you the sequence of staining in xerophthalmia, what should be the right sequence? So of course, because you know conjunctiva is more often stained by lissamine green, rose bengal, and thirdly by fluorescein dye. Got it? Chalo. All right. Got it? Okay. Now next is, this is lissamine green and this is rose bengal. एक चीज का ध्यान रखेंगे, rose bengal is seen in normal light. You see it in normal light, and which is bright light. Another important question, potential MCQ. Lissamine green is also seen in normal light, but that normal light should be relatively dim. But fluorescein dye, I have already told you what? I have already told you it is seen in cobalt blue light. It absorbs blue color but emits green color. Done? All right. Okay. Now next is ocular adnexa. So what is this? Improvement with ice pack application. Also it is improved in IV injection of neostigmine. बताइए क्या है जी ये? This is a case of ptosis with ptosis. भाई myogenic ptosis, which is myasthenia gravis. Your previous year question. Myasthenia gravis. Very good, yaar. All of you are answering wonderful. Love to all of you. Okay. What is this ptosis? Can you see that there are upper eyelid crease absent? Important sign is upper lid crease is absent. So which ptosis is this? This is your congenital ptosis. Very important. Very good. Yes. Very good. Very good. Sahil, Rakesh, Shah. Very good. Tanya, Muhammad, Shehbaz, Nisha, very good. So proud of you. What will be the treatment? This is your previous year question. If there is upper eyelid crease which is absent, this is congenital ptosis, which is the surgery of choice. Because why there is upper eyelid crease absent? Because levator palpebrae superioris is not developed at all. So you need to pull the upper eyelid. So for that, you need to put a sling and pull the upper eyelid. And that sling surgery is frontalis brow sling surgery. Frontalis brow sling surgery. One important point to remember, it can also be used in Marcus gun jaw winking syndrome induced ptosis. Right? Two important points I have given you. Okay. All right. Now, what is this? Façonella servate. It is usually indicated in acquired proptosis. Oh, acquired ptosis. Yes. Acquired ptosis. So, Façonella servate procedure. Levator resection can also be done in acquired ptosis, because in these acquired ptosis there is no absence of levator palpebrae superioris. Only in congenital ptosis there is absence of levator palpebrae superioris. So you cannot do levator resection procedure and you cannot do Façonella servate procedure. Just the names. Let's not go into that depth. What is this surgery? बताइए. So this is your Jones procedure. Just the names. Jones procedure. Dear Rohan, so this is a very crisp and concise revision session. I hope you are able to cope up with this, hai na? So Jones procedure. So this is done in which surgery? Entropion. Entropion correction surgery. You go for Jones procedure. Number one. What are the other name of the procedures that can be done in entropion? Bix procedure, just the name. Quickert procedure. So I gave you three surgeries, 1, 2, 3, which you will do in entropion. Just three surgeries. Don't forget there is another condition. You call it as ectropion. In ectropion, you do two types of surgeries. One is VY surgery and second is Z-plasty. So how will you remember? Alphabetical A, B, C, D, E, F, G, H, VY and Z. It is done in ectropion. Just the names. In entropion, we have got Bix procedure, we have got Quickest procedure, we have got Jones procedure. Got it? Okay. All right. And now, last slide probably. So, painful lid swelling with small elevation at the root of hair follicle. What is the diagnosis? You have to take care. If you have a sty, don't touch your eye with your hand and then touch the other eye with your same hand. You can develop sty. So this is hordeolum externum. The other name of hordeolum externum is sty. And your previous year question, most common etiology is infection of hair follicle. Infection of hair follicle, right? Infection of hair follicle. If that is not in the option, infection of hair follicle, if that is not in the option, then you will mark infection of gland of Zeiss. Got it? Infection of gland of Zeiss, right? Now recurrent condition. If the patient is having recurrent styes, you will suspect of having refractory errors, because once the child is not able to see clearly, the child will have a tendency to continuously keep rubbing the eyes, and in that context he will introduce the infection from his hands into the eyes. So you will check out for refractive error, है ना? So that is one important. What will be the treatment? Treatment क्या होगा? Treatment is hot fomentation, and of course antibiotics, anti-inflammatory. Hot fomentation, antibiotics, and anti-inflammatory. Diclofenac, paracetamol you can give, है ना? So that's it. Now yes, last is chronic non-tender mass, recurrent condition, and what will be the treatment? So chronic non-tender mass which is away from lid margin, and that is what? That is your chalazion. Some people would love to call it as chalazion. It's one and the same thing. Recurrent condition. If the patient is having recurrent chalazion, think of sebaceous cell carcinoma. What will be the treatment? Simple treatment. Go for incision and drainage. One liner, incision and drainage. And of course, if I talk about ophthalmology Viva, what to study from Viva? For Viva, so one is you can go for Parsons, but of course Parson is a one big book, so you just go through pterygium, chalazion and cornea, and high chances that you will score really good in your Viva as well, है ना? So this has been a very common joke, and with this, don't think too much. आराम से पढ़िए, just enjoy reading all the subjects. Every subject is important. Once you will become a doctor, trust me, you will love treating the patients, and to be able to treat the patient, it is very important to have a basic knowledge. So each and every subject is important. So anatomy, physiology, biochemistry, pathopharma, all subjects are important, and don't take stress. बिल्कुल स्ट्रेस नहीं लेना. इट इज एट द एंड ऑफ द डे, इट इज जस्ट एन एग्जाम. एक एग्जाम ही तो है यार, और क्या है? अभी नहीं क्लियर हुआ, अगली बार हो जाएगा, दैट्स ओके, बट डोंट मेक इट योर लाइफ और दैट सिचुएशन कि नहीं हुआ तो पता नहीं क्या ही हो जाएगा. दैट्स एब्सोल्युटली ओके. राइट नाउ ऑल द सक्सेसफुल पीपल यू सी, दे आर द tip of iceberg. You don't see the struggles that went underneath, right? Once you will have that mindset, that thought process, trust me, any exam will not stress you out, right? And in the end, of course, I hope you enjoyed seeing all the memes and all the fun things, and I hope it was a good session, and I hope that this session is going to benefit you in a very beautiful way. And I am hopeful that once the results will come, and you will, of course, you will come to our DAM studios here where I am standing right now. You will sit in front of us and you will give interviews. If you want to follow me on Instagram, so my Insta ID is I_Manish. You can also follow DAMS Daily. So that Insta handle is DAMS Daily. And of course, for daily dose of motivation, you can follow Sumer sir's Insta handle, which is Sumer Doc, and you can also follow Deepti ma'am's Insta handle, which is Deepti Behel. You can also follow us on Telegram and Telegram. So my handle is Dams Ophthalmology, right? You can also follow Dams Daily E-Medicos official group. You can also follow Dr. Sumer sir's and Dr. Deepti ma'am's group. But as I always say, picture abhi baki hai mere dost. I have got just 3-minute long video in which I have included my real patients, and I want you to actively participate in that. I am going to run this clinical video. Now you quickly need to tell me what is the diagnosis. Just 3 minutes. Okay, what is the diagnosis? Yes, quickly. Yes, what is the diagnosis? What do you see? You can see proptosis. You can see what? Non-reacting pupil. You can see conjunctival chemosis. You see periorbital edema. What is this? Yes, quickly. So this is your orbital cellulitis. Orbital cellulitis, right? Okay, now this is the second question. What is this? What is the earliest sign of thyroid eye disease? Can you see? Can you see the right eye? Can you see the right eye? Can you see the scleral show? So that means there is upper eyelid retraction. So this is upper eyelid retraction. What is this? When you ask the patient to look downwards, can you see this eyelid is going completely down, but this eyelid is not going completely down. So this is lid lag in down gaze. So in this patient, we saw two things. One is Dalrymple sign, upper eyelid retraction, due to which there was scleral show. Second is there is lid lag on down gaze, which is von Graffe sign. I hope you have understood. Okay, now coming on to third. What is this? So I told you about Knapp-Ziegler test. So Knapp-Ziegler test, you stand at the back of the patient asking the patient to look upwards. So here I am standing in front of the patient asking the patient to look upwards. This is worm test. Knapp-Ziegler and worm. But you need to remember Knapp-Ziegler test. You need to remember just the Knapp-Ziegler test. This is just to show you, can you see which eye has proptosis, right or left? The patient's right or left? The patient right eye has. This is qualitative test. So this is your worm test. I hope you have understood. Patient jab tak nahi dekhoge, tab tak nahi samajh mein aayega. I want you to have clear cut concepts. Done? Okay, wonderful. Now, yes. Now coming on to next patient. Yes, next patient please. Yes, beautiful. Now, can you see the earliest feature of anterior uveitis? What is this? These are actually cells in the anterior chamber. Trust me, it took me at least 30-40 minutes to capture the literally cells rotating in the anterior chamber. I told you which is the earliest diagnostic feature. It is the cells in the anterior. Can you see the cells in the anterior chamber? Okay, what is this now? Can you see the mutton fat KPs? Can you see the KPs which are present on the cornea? ध्यान से देखो इस बहरूपीय KP को. नजर आ रहा है? Yes, बिल्कुल नजर आ रहा है. So these are KPs. Now what is this? Can you see? So this is your posterior synecdoche, and in the posterior synecdoche, when you will put a drop of mydriatic agent where it is synecdoche with the lens capsule, it will not dilate, but wherever it is free, it is going to get dilated, right? So this is known as festooned pupil. Festooned pupil is irregular zigzag pupil due to synecdoche at multiple places. Very good. You people are answering really beautifully. I am so proud of you. So that was your festoon pupil. Now what is this? This is, can you see the difference in the size of the eyeball? This was the one child who had visited me in PGI. So left eye, what is this? Boophthalmos, bullseye. So I wanted you to show you at least bullseye. So can you see left? Can you see the left eye is large? Okay, what is this? Can you see the eyelashes which are very thick, which are very large? This is what you call trichomegaly seen with latanoprost. What is this? This is your central retinal artery occlusion. Can you see cherry red spot on the macula with retina which is pale or milky white in color? Can you see that? So this is your CRAO. Done? Okay, CRAO. Now what is this? What I am doing? I am staining the eye. Why? Because I want to show you. I'll stain the eye with fluorescein dye. What is the color of this fluorescein strip? It is orange color. It is going to absorb blue color and going to emit the green color, right? Now you will see whether this is a case of dendrite or pseudodendrite. So what I am doing is I am examining this patient in the slit lamp. What is this? This is pseudodendrite. So this is a case of herpes zoster ophthalmicus. This is a case of herpes zoster ophthalmicus. Yes. What is this? This is a case of epidemic keratoconjunctivitis. Can you see pink eye? Abhi thode samay pehle, 2-3 months back, there was an outbreak of epidemic keratoconjunctivitis. So that was a case of epidemic keratoconjunctivitis. What is this? This is trichiasis. Trichiasis is misdirected eyelashes. Misdirected eyelashes. Can you see misdirected eyelashes? Okay. Now moving ahead. What is this? This is kind of funny. So this is a case of Congenital ptosis. Can you see the lid crease is absent in the right eye? So when I ask the patient to open the eyes, what he is doing? So there are reflexes in the child. See. So this happens. So, you know, that is the beauty of being a doctor. So you tend to interact with children, adults, and there are some light-hearted movements in the OPD as well. Hai na? All right. So this is the other patient, and this is a case of your chalazion. Chalazion. This is a case of chalazion. What is the treatment of choice for chalazion? The last video of today's 2023 DVT session by me, Dr. Manish, ophthalmology educator at DAMS. So what I am doing, I am operating the patient with IND, incision and drainage. So what I am doing is, I am applying chalazion clamp. This can be asked in your spotters or instrument. Now I am going to give a vertical incision. You will see coming out of the lipogranulomatous inflammation, and that is chalazion. I am scooping the contents out of the empty vesicle now. So operating this patient, so this is IND, which is treatment of choice. Now I am applying antibiotic ointment. I put the patch and done. I have got my 5,000 rupees and the patient's swelling is gone. So patient is happy. I am even more happy. Hai na? So I hope it is clear. So guys, that was it from my side. I hope you loved, you enjoyed coming to my session, and I hope to see you soon. It was all my pleasure. So today was my offline session. Tomorrow I'll be live in DAMS auditorium, which is at Siri Fort. So thank you very much. It was my pleasure. I hope to see you soon. And in case, even after the class, if you have any doubts, you can always come to me reach me via WhatsApp. I am sharing my contact number. You can send me WhatsApp message. So I am available on WhatsApp. Any doubt you have post class, you can send me a message. I'll be happy to reply to you via voice message or even by typing, so that ophthalmology is one of your stronghold subjects for your NEET PG 2024. Thank you very much. It was all my pleasure, and good night. Bye bye. Now next session is by none other than our dearest Dr. Tushar sir. So Tushar sir must be waiting outside and he must be thinking, Manish, jaldi khatam kar, itna time laga diya. Thank you very much, and thank you very much sir for waiting, and bye bye everyone. Love to all of you. I hope to see you soon. Bye bye.